Okay, you're recording now.
Okay. I just wanted to give you a heads up there, Representative Wallner. We're live and recording. So, good morning. It's 9:31. I noticed we have a couple of members that still are to log in, but our clerk is in another committee meeting. So we're going to go ahead and get started. There needs to be a checklist written for read for the public. As chair of Division 3 of the House Finance Committee, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic and in accordance with the governor's emergency order number 12 pursuant to Executive Order 2020-04 as extended, this public body is authorized to meet electronically. Please note that there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the governor's emergency order. However, in accordance with the emergency order, I am confirming that we are providing public access to this meeting by telephone and with additional access possibilities by video or other electronic means. We're using Zoom video webinar for this remote meeting. All members of the committee and the staff of the state agencies with agenda items have the ability to communicate contemporaneously during this meeting through this platform, and the public has access to contemporaneously watch and or listen to the meeting on Zoom or phone following the directions and links provided in the House calendar, starting in House Calendar 8 and proceeding from there. You can find the House calendars hanging conveniently. We are also providing public notice of the necessary information for accessing this meeting that's in the House calendar I just referenced. We will be providing a mechanism for the public to alert the public body during the meeting if there are problems with access. We want to make sure we maintain access. So if we're not, email us at lba_fiscal, FISCAL, at leg.state.newhampshire.us. And if we do find that the public's having trouble accessing this, we will go ahead and adjourn and reschedule. Please note that if we take any votes today, and I don't suspect we will, they will be done by roll call. So I see that our clerk is still away. So Representative Bean, will you take the attendance, and let's have each member make sure we know if there's anyone else in the room so we comply with the right to know law.
Yes, sir, I will. Representative Rogers.
I'm present. This is Catherine Rogers. I am in Concord, alone in my apartment with my dog.
Representative Nogstrand.
You're muted.
Sorry, I'm in my dining room in Hanover alone.
Representative Wallner.
I'm in my home in Concord, New Hampshire, and I'm alone in the house.
Representative Earp.
I'm here, present, and home alone in my office.
Representative Edwards.
I'm here in my home office in Auburn. I have people in the house, but my office door is shut.
I'm Representative Bean. I'm present, and my wife is here wandering around. She's going to be leaving shortly. Representative Weiler.
Representative Weiler's at the chairman's meeting with the speaker. He'll join us when he can.
Looks like we're all set. Thank you.
Okay, so before we kick off this morning, I just want to, there's been a bunch of emails floating around relative to our plan for Wednesday afternoon. And because it's a little atypical, I just wanted to also be able to describe in real time what I think we're doing. I think what we're doing is that we wanted to make sure that we were really being accessible to the public, and that we wanted to have our committee members reach out to individuals who we think have a particular point of view that we need to consider in order to make our decisions relative to the DHHS and veterans home budgets. So each member was given a 20-minute time allotment. There was no requirement to use it. For example, Representative Weiler is not going to have a guest come in, but we'll start at 1:30 on the afternoon of the 10th with a 20-minute allotment per speaker or speaker group. I think we could be done by 3 o'clock. And if we go a little long, we'll go a little long. It's an aspirational goal, Representative Nordgren, right? So we'll, and then there was a question by Representative Rogers today about can they present PowerPoints? And I think that it's important for us to learn. So if a PowerPoint will help us learn, then yeah, they can use a PowerPoint. I would just encourage them to maintain their time discipline so that we can hear everyone in the time allotted. So so we'll figure out how to get a PowerPoint up. I think Mr. Ripple can get them in a position to be able to share. So the only thing that's outstanding is if for each of you who have invited somebody, would you please just get clarity before the meeting on which line numbers or which account numbers they're really talking about, so that when they start, we've already figured out what aspect of the budget we're referring to, and that we've done our homework to get our head ready to hear what they have to say. So if we could get them to specify which aspect of or which line items of the budget they're referring to, that would be great. With that, are there any questions from the committee relative to what we're doing on the afternoon of March 10th? Okay, not seeing any. Mr. Ripple, why don't you go ahead and get us going for today's agenda?
Yep, sure. Today you have the Division of Medicaid Services, and Karen is here as usual, and the Director, Henry Littman, is here as well, along with a few other people from the department.
Good morning. You said that, oh, yep, I see Henry now. Okay, great. Chair, may I ask a question about Wednesday?
Yes.
So we have public health scheduled to present on Wednesday. Is your plan to just have them present in the morning, and then if they need longer that they would go into next Monday? They do have about 90 accounting units, so it does take some time.
So what I thought we'd be able to do is if we start at our normal time that's in the House calendar,
Yes.
And just from the way these have been paced, I thought we could wrap up by 1:30.
Okay.
And then from 1:30 on is when we'd have the other speakers come in.
Okay.
If you don't think 1:30 can work, then, you know, let's talk about it and I can slide our guest speakers. That's really kind of the optional part of the day and the flexible part of the day. We need to hear from you all in the public health group without, you know, causing you to go so fast we're missing your points.
Okay. All right, great.
The
So
other
we'll
thing-
just,
Sorry,
ahead.
Karen. The other thing I would point out is that you have part 2 of public health scheduled for Monday, the 15th. So if it goes over on Wednesday, they can come back.
yes.
Very good.
Okay, great. I'm going to turn it right over to Henry. Henry, are you good to share your screen with your presentation?
I am. I would ask if Kevin, though, could bring over Athena Gagnon, the Director of Medicaid Finance as well.
Oh, thank you. Yes.
Sure.
Thank you, members of the committee, Chairman Edwards. I'm going to share a screen with a PowerPoint to start, if that's okay with you.
Great. So, Mr. Lippman, I think you've done this before. If during the course of the hearing, if one of the committee member raises their hand to ask a question, I'm going to interrupt you and I'm going to try to raise my hand to find a graceful closure of your thoughts so that we can ask a question.
Sure, please. I expect that, and thank you for letting me know. Wrong one, sorry. So like to just share what we had planned for an agenda, which I think is comports with what you were expecting, Chairman Edwards. And if that's okay, I'll just launch into it, if that's all right.
We're all ready.
So just as a setting, Division of Medicaid Services, this is where you'd find our department identifiers. I think the two key people in the presentation today will be myself and Athena Gagnon, the Medicaid Finance Director. We also have with us today the administrator of our quality program supporting Medicaid, Patrick McGowan, and David Wieters, the Director of Information Systems for the department. And I'll work them into the presentation at appropriate times, if that's all right. So I think one of the things you wanted us to start out with is what is the mission and vision of the Division of Medicaid Services?
Henry, the
Yes,
slide, it's not moving. We're just still seeing the presentation, not the slides.
okay. Thank you for letting me know.
No problem.
If you're screen sharing, it should just show what you're seeing.
Yeah,
If I had to guess, Dave just went off camera, so he's on his way to your office.
There. Well,
try again here.
I'm actually remote today, so I'm not gonna be able to go to his office.
Oh, darn. I thought that's why you went off camera.
beautiful background you have there, though, dude. Excellent choice in backgrounds.
Are you seeing my slide now?
Nope, the sharing stopped.
Okay.
And Athena, I get the humor of your background, by the way, just in case you're wondering if anyone gets it.
Are you seeing it? Are you seeing it now?
Yes.
Okay. Thank you. I think maybe it'll work better if I work it this way as opposed to doing it through the actual screen presentation. So I think where we were, we're starting on the mission and vision of the department, Medicaid, Division of Medicaid Services. Again, in this division, a large part of what we do is provide health insurance coverage to a variety of populations. Medicaid is largely a categorical program. For example, the individuals who are elderly and poor, the aged, the blind, the disabled, and so forth. We provide a managed care program, Medicaid care management program, through 3 commercial MCOs. And what we look to do is to run that program effectively and efficiently, and also just because we're caring for so many in New Hampshire, nearly 1 in 7 at any one time currently, we want to make sure that they're receiving quality services with good customer service. And in addition to the managed care program, we're also involved in a fee-for-service component. So covered a couple points on this slide where we are a publicly funded program, and we'll get into what components the state pays for, other funds pay for, as well as the federal government. Today, we, my first statistic here is as of the end of January, we're at 214,000 individuals, and just to update those stats, as of last Monday, we're covering 215,503 people in total. 72,793 of those individuals were through the Granted Advantage, or sometimes known as Medicaid expansion. and 142,760 in the standard program, which includes covering the children. And the increase since the start of the public health emergency, the week of March 16th, we've seen a total increase of 38,083 individuals, 21.5% increase. The granted advantage component, which is a component that's driven off of income, saw the largest increase, 41.6%, or 21,378. And the standard program is up 13.3%, or 16,705 individuals. Our division operates programs as well as provides the interface with the federal government, Centers for Medicare and Medicaid Services. We provide support to other divisions that you've heard from or will hear from over the course of your hearings. And basically, we're the Centers for Medicaid and Medicare Services looks for a point of contact, and that's me as the Medicaid director. But we're basically, I describe Medicaid as a team sport. We support in both on the technical side and on the federal claiming side these divisions. I won't read these all here to you, but they'll be all the divisions that you meet with over the course of your meetings. Offering a Medicaid program is technically elective for states. All 50 states participate in the Medicaid program. Actually, there are also territories of the United States. I think there's 7 or 8 territories that also participate in Medicaid. If you do participate as a state, there are certain things that you have to do in terms of offering. I see you're asking a question, Representative Edwards.
I do. As you go through this, I hope part of what you think we're going to walk away with is I would like to understand the extent to which Medicaid is offered as a managed care service, and that we have so many initiatives in DHHS to build out a systems of care model. I'd like to know the extent to which the Medicaid component of our health system is actually amenable to being wrapped in a systems of care model. And that's kind of, I don't know if you're going to find that in your slide deck, but when you get to the right point, I'd really like to understand how those concepts, that your program and those concepts fit together.
So if I could digress and answer that question directly now, if that's all right.
Sure.
New Hampshire has what is described as a 1915 B waiver, which is a waiver that allows the state to, as far as, if you will, acute care services like hospitalization, prescription drugs, your typical health insurance bundle is nearly all of our enrollment, the 215,000 I was talking about, are in managed care. We have what we call next day enrollment. So when someone gains eligibility, they go right into a managed care, one of the MCOs. And so in terms of the services that would represent health insurance as you typically would think about it, they're mostly, nearly the entire population is, and those that are not are usually in it only temporarily, not in it temporarily, excuse me. There are other waivers that you'll hear. I think LTSS is later on today, which aspects of that are outside of the managed care program, most notably things like the home and community-based waivers. And hopefully that gives you at least a little bit of an introduction in terms of who's in and who's out at this time.
Okay.
And so we'll be covering a little bit more about the different services that are mandatory and optional later on in the presentation. Also, the key thing in terms of how much does the federal government finance sometimes we described as the FMAP, the federal matching assistance percentage, or sometimes you'll hear it with another acronym, but basically it's how does the federal government participate in offering in it. And for New Hampshire, it's always at least 50%. And we'll get into that a little bit more later on as well. As part of the Families First Coronavirus Response Act, the public health emergency from a Medicaid standpoint, offered states, and I know of no state that has decline this. If you maintain continuous enrollment during the public health emergency, that the state is eligible for enhanced federal matching percentage on the standard population. There's basically the adults, and in that category, it's 6.2%. It's about 4.5% in the what we call the children's group, or CHIP sometimes. And then for the Granted Advantage program, which is the Medicaid expansion, there is no enhancement because the federal match is already at 90%. And this enhanced match goes through the quarter ending, which the public health emergency ends. And when we talk about public health emergency, we're talking about the federal declaration of that. So I thought might be helpful to have some comparisons out there in terms of how does the federal landscape look like compared to New Hampshire. And let me see if I can make this a little bigger for you. So just in terms of the percent of population covered is sort of the top. Federally, US-wise, 28% of the population is low income, and 21% of the population is covered by Medicaid or the Children's Health Insurance Program. In New Hampshire, we don't have a separate Children's Health Insurance Program, or sometimes known as CHIP. It's all part of our Medicaid program. In New Hampshire, by contrast, 16% of the population is considered low income, 14% are in the Medicaid program. And in terms of New Hampshire being an expansion state, the Granted Advantage program, and these statistics go back to 2018-19 period. Just before the public health emergency, the most recent number would have been 51,000 comparatively in terms of the number of people are covered in the adult expansion group. And there are now 39 states that have adopted, and I have a slide later on that will also give you a sense of those orange states here, which ones are moving towards offering expansion. I'd also note that in the bill that was passed by the US Senate, there are incentives for those orange states to adopt expansion as well. In terms of who Medicaid covers, I just thought it was kind of interesting that in terms of adults aged 19 to 64, nationally it's 1 in 7. In New Hampshire, it's 1 in 10. For children, it's 2 in 5, about 60%. In New Hampshire, it's 1 in 3. A third, 2 in 5 is 40%, 1 in 3, 33%. In terms of nursing home, it's 5 in 8 at a national level, about 60%. And in New Hampshire, it's about 2/3, 66% that are covered. Individuals with disability, we cover 1 in 4. Nationally, it's 1 in 3. And in terms of the total population of Medicare individuals who also have Medicaid as sort of a secondary, nationally, it's 1 in 5. In New Hampshire, it's 1 in 8. Down the bottom of this chart is the eligibility levels. You'll see that New Hampshire, compared to the nation, has eligibility that's basically comparable in every category except for children. We cover a little bit greater number of children, but as a percent of the population that are children, we actually cover less compared than nationally. Moving to the next slide, the top part of this slide is just, where does the money get spent? And while adults and children represent the largest part of the population, it's the elderly and disabled which count for the greatest part of the expenditures. And nationally, it's 23% are elderly and disabled, and they count for 61% of the expenditures. In New Hampshire, historically, it's been 20% elderly and disabled and 59% of the expenditures. And when it's all said and done, New Hampshire spends about $1 in $6 in the healthcare system, as is done nationally, and about $1 and $2 are going to support long-term care services. And there's a chart on the right here that kind of breaks it down, but largely New Hampshire spending follows, I think, our demographics. We have more elderly and disabled, an older population. But even with that, it still tracks very much the national scene. We'll talk a little bit in the presentation about different eligibility groups. This slide's just one way of looking at it in terms of from a low-income individuals with disabilities and elderly individuals. And then the next slide is basically where expansion stands at the moment. There are now 39 states plus DC that have adopted Medicaid expansion. And there are 2 additional states, Missouri and Oklahoma, that are in the process of coming on board. I sort of touched on this chart. This is a week earlier than the updated numbers I gave you, but this is how in the department level we've been tracking what's been going on since the start of the public health emergency. And again, I won't read off all these statistics, but you can see here that the darker red areas are where we're seeing the greater percentage increases, and on the right-hand side is the percent change in the number of people covered.
So I noticed the bottom stat, children's with disabilities in-home care. Is it because of COVID? Clients don't want us in their homes, or do we have fewer workers willing to go into homes, and therefore we're in decline in terms of the number served?
I think it could be that within the Medicaid program, people's eligibility can change within different groupings. It may be that they moved to they may have aged out of one group and went into another. It may be that they fell into another area, but we're talking about 50 children, and you can see that in other categories are low-income CHIP, non-CHIP children, which is the lion's share, went up over almost over 7,758 children, and another 2,161 in low-income children. And it could be that they either fell into one of those groups or one of the other disability groups if they aged out of being a child.
Thank you.
Can I ask a question, Mr. Chairman?
Oh, yeah, thanks for saying something. I missed your hand. Representative Irf has a question.
Could you just clarify the difference between low income and Medicaid CHIP?
Sure. If you remember on one of the earliest slides, there's was a showing where New Hampshire compared to the, let me just go back to it, that might make it easier to explain. If you remember looking at the children's eligibility level, here we're at 323, and nationally it's at 255. What this is really representing is that New Hampshire adopted a number of years back that children who are 196 up to, I think it's 323% of poverty. If you cover that 196 to 323, you get an enhanced federal match on those children. And so that's what I think you're seeing there, is that the CHIP population is that group of children that get the enhanced match because they're in a higher income category. Does that answer your question, Representative?
So it's an age thing.
It's not an age, it's an
income thing for children.
Yes, if their family income is a little bit higher, again, the federal government was trying to provide states with an incentive to cover more children. And certain states do, and New Hampshire is one of them.
Thank you.
One of the other things I thought you might find interesting is kind of how geographically the growth in enrollment has transpired. And we've broken into 3 groups here. The granted advantage, which is basically only an income-based people that are less than 138% of the poverty and are typically childless adults. You can see that the growth, followed, I think if you kind of look at it, it's spread around the state, kind of, the Portsmouth area, the Rockingham County, and over in Grafton County and Carroll County are some of the higher spots, but it's pretty universally important to a large group of individuals to have gained coverage through this program. I think a lot of your hospitality, your restaurant individuals who may have lost their insurance coverage or lost income became eligible and were able to be picked up. As I mentioned earlier, it's over 21,000 individuals have picked up coverage since the mid-March timeframe. The standard program, which is more categorically driven, you can see that the growth rate there hasn't been as high, but again, if you look across the state, there's, it tends to follow a somewhat similar pattern as the granted advantage as people lose income. And then the disabled population, again, people aging into it, a little bit lower growth, but also an important aspect of being able to provide coverage to those individuals. And again, this has not been an economic hit that's just been isolated to one part of the state.
Do you have another question there, Representative Irf?
I do. Thank you, Mr. Chairman. So just to clarify for my own sake, the granted advantage is expanded Medicaid?
Yeah, Medicaid expansion, yes.
And the standard income base is the children's 90-10 match?
It could be anyone who is in the categorical areas. It could be other than the blind and disabled and elderly, it's the other groups of standard coverage. A lot of this could be children. Yep.
Well, where's the chip, the Medicaid chip piece fall?
They'd be in this category as well.
Okay, so one of several groups in that category.
Yep.
All right, thank you.
Are there any other questions? You're free to continue.
Okay. So I know from sitting into Division 3 in the prior budget and in this one, that understanding not just the financial numbers, but what's being done to improve the program is important. So the next number of slides are about what we're doing in quality and developing the efficiency and effectiveness of the program. And I'm going to invite Patrick, if you could, Patrick McGowan, who is the administrator of our Medicaid quality metrics, if you could come in and talk to a few of these slides here for us.
Sure, absolutely. And thank you for the opportunity. So this slide here highlights sort of the core goals of our Medicaid quality strategy, which is required by the Centers for Medicaid and Medicare Services when you have managed care. These are sort of the high level 6 goals that we have. First, starting, and I think we give a link at some point that will go to the full quality strategy that you can read, but this was more for sort of the highlights. So the first one in the upper left-hand corner is to assure delivery of quality and appropriateness of care. So this is the section where we do have quality measures that look and monitor our members getting preventative care or actual evidence-based treatment being provided. Was there a question, Representative Irf?
Oh, yes, Representative Irf, you got your hand up?
Oh, sorry.
Good catch, though. I didn't notice it was still up.
Sure. I'm just not used to talking so much without somebody chiming in. So anyway, so then below that, we look at assure access to quality care. So whereas before we looked at the care that was being provided, well child visits, vaccinations, sort of the preventive care. The next one looks at, are you actually able to access that care? So for that, we look at our managed care organizations, provider networks. Do they allow members to have the ability to travel within a reasonable time to providers' offices? And are there enough providers in that managed care organization's network of providers that would allow them to have all the services that a typical member could need. We also look at utilization data to look at trends as far as how members are accessing services, to monitor to see if those change at all, which could indicate changes in service patterns might mean that there could be an issue with members accessing care. And then we also do look at member grievances, which is a sustained filed complaint to the managed care organizations. We do look at appeals when services are being denied, if members or providers on behalf of a member are reaching out to file that the MCO reconsider the action. Those can all be indications of an access to care, of members accessing care. And then finally, we also do have member experience of care surveys, where we get details back about how members have, if they're getting the care that they need really in the time that seems reasonable to them. And a lot of these are all really industry standard quality measures that we're using. Below that, we have assure vendor contract compliance. We'll talk about an external quality review organization that we have in a few slides, but we do a annual audit of the MCOs based on their contract with the state, and particularly to see if they have policies or procedures that are in place in all areas of the contract. We also do have the ability to enforce liquidated damages. We have some internal reports that we do calculate for the Medicaid director to see on a regular basis how those managed care organizations are complying with the contract. Then we move up to the upper right-hand box, which is manage continuous performance improvement. This gets more into the areas of, okay, we see rates that, or quality measures where we think things should be better. What do we do about it? Well, we do have a quality withhold and incentive program where we do withhold a percentage of the MCO's, what we call capitation rates. And we set goals, in particular quality measures. And if the MCOs can meet those goals, then they can get back what was the revenue that was withheld from them. There's also a component of that where they could get a bonus. We also ask the MCOs to do alternative payment models with providers, to where they're incentivizing providers to reach certain quality targets. We have a few other programs as well, including our performance-based auto assignment program. So MCOs that score higher on quality metrics, they can actually receive more members that didn't actively choose a plan when they are determined eligible for Medicaid, and they could be assigned to that plan. And then we have just general performance improvement projects that we do. Target population health activities is the next quality, the quality strategy. And to those, that's where we have particular populations that are priorities in New Hampshire's, particularly those with mental health, substance use or misuse, some of the special need members that Henry's already talked about, particularly with children, foster care children, and then also looking at disparities as well.
So
And then the
for
final.
McGowan.
Oh, sir.
Yeah, I'm sorry.
Sure.
Under a managed care model, my simple understanding is that other than the assuring vendor contract compliance, that the contract has the MCO doing most of the other 5 boxes. And so I'm just curious where our value add is relative to just adding layers of management redundancy. Can you
Actually, if I could, Representative, I think all the boxes that are here are requirements of the state in terms of overseeing, if you will, its contractors. There are pieces that the MCOs do of all of these areas, but in terms of, if you kind of think of it as sort of the clerk of the works in a construction project, making sure that the construction's actually completed to specifications, we have a small group of individuals that make sure that that all of that happens. We also are involved in setting the goals based on reviewing the data and the metrics to make sure that the areas where the MCOs are focusing on are ones that fit the state's priorities. Hopefully that's a little bit helpful. And we can maybe, as we jump into a few other slides, it might become a little more apparent what we're doing and versus what we have to have independent third parties by regulation do as well.
Sure. So as you were talking, I was thinking, what kind of external benchmarks are there to determine how large staff the state should have to oversee these contracts, whether it's a purely judgment or if there's some benchmark that we're looking at and considering? I can wait to the resourcing part of this though.
Sure. Patrick, are you ready for the next slide?
Absolutely.
So
here, this is one value add we do provide for members using a lot of our quality metrics. We do have a consumer guide that members who have recently been determined eligible or during an open enrollment period have to pick a managed care organization. It's a 2-sheeter you're seeing on this slide. One page, but this link will bring you to the actual guide. Our vision was for members, kind of like when you're making a purchase on Amazon, that you can see how the health plans are rated in various quality measures. And we tried to do a broad list of them, both children's measures, overall satisfaction with the health plan, well child visits to members, how the plans do for those, and then managing some chronic conditions such as asthma, heart disease, blood pressure. All of those I think are on the second page. We also compare the health plans to the national Medicaid average. So there's some benchmark that they're hanging on to. These are all driven by quality measures that you may have heard the acronym HEDIS before, but they're an industry standard. The acronym is probably less relevant in what it actually stands for, but it is sort of the industry standard on how health plans are evaluated, both for clinical and ambulatory metrics. Any questions about this?
Patrick, I just add that, for example, on the top measure that can change year between year. The prior year, it would have flipped in terms of one plan being ahead of another. We have a third plan now, which they have to have a certain amount of experience before you can include them in this measure. But Patrick, I just want to confirm, is the top line is their national evaluation, not just New Hampshire, correct?
No, that is the New Hampshire evaluation.
Okay. We're ready. Go to another slide.
If there's no questions, yes. Here then, we just wanted to give you a little flavor for some of the key performance indicators of how we evaluate the plans. So you'll see 1, 2, 3, 4, 5 different metrics that we look at. We do have over 200 metrics that we're evaluating at different periodicities. Here you'll see the I think the dark blue is the New Hampshire Medicaid managed care rate. That's the total program rate. And then the kind of more turquoise color, we're actually able to calculate what New Hampshire commercial payers have scored on the same rate. And then we also add the national Medicaid average for context. The licensing on that data prevents us from actually publicly sharing the rates. So that's why you'll just see a bar, but no value above it. So, and then some of the measures you'll see, well child visits in the first 15 months of life, breast cancer screening, controlling blood pressure, and then the last 2 are measures of receiving follow-up care after emergency department visits for mental illness or substance use. Typically, in most of our quality measures, we do tend to score higher in New Hampshire than the national average, but it's nice to see the commercial perspective to where you can start to see how we fare against other products in New Hampshire or other populations.
I have a couple questions about this slide.
Sure.
At what age does the program begin breast cancer screening?
Off the top of my head, I don't have it. I can get it for you though.
Okay, and the reason I ask that is because the literature was bouncing all around for a while on what the right age is for women to begin regular mammograms. And so I'm just curious how that settled down and if we're complying with it. Then the other one that I'm curious about is I see the follow-up visit after emergency room visits for mental illness and then for substance abuse. And the substance abuse is obviously substantially lower. Does that imply that it's substantially harder to go do a follow-up for substance use?
I think the New Hampshire data would show that. I mean, this is a measure that it's kind of ironic because New Hampshire scores better. We're probably about top in the nation for this measure, but it's still a rate that we believe is unacceptable. So comparatively, is it easier than mental health? I don't know, Henry, if you can speak to
I
that.
think that
But the data would suggest the opposite, that it's easier to do a mental health follow-up.
Oh,
than
that's what
a
I meant. Yeah,
substance.
yeah.
Okay. So then I guess given that that's just a clear observation from the data, what do we need to do differently to get that 27% at least twice as high?
So if I could, Patrick, I think that we look at it from a number of different angles. I think Patrick talked earlier about the programs that we asked the MCOs to consider in terms of APMs or ways of developing value-based care. We've asked the MCOs to develop relationships to improve that follow-up with providers. They have requirements in the contract to do performance improvement programs in addition to that, as well as in our withhold measures incentives, we include it there. So we're trying to come at it from a number of different angles. And as Patrick said, while we may be doing very well comparatively to the nation, it's a number that we obviously want to have much higher, particularly where New Hampshire has been one of the higher states affected by the SUD crisis.
We also do have some process measures as well, Chairman Edwards, that as far as how when members are discharged from the ED, the MCO is required to make several contact attempts for each of those members. So we do track that as well. So it certainly is not a measure that doesn't have multiple quality initiatives attached to it. So
I think it's probably one of the areas between mental health and SUD where we're spending a lot of time trying to come from all different angles to improve the delivery of care.
And the breast
Okay, so
cancers.
sorry. Just so you know, my frustration with that answer is I'm sorry. I may be just a little impatient today, but I'm just hearing that we're going to require more planning, more documentation, more conversation at the staff level, but fundamentally we don't know exactly who needs to do what to get that number higher.
No, I don't think that would be accurate, Representative. I think that we have specific measures built into the contract in terms of performance metrics that require, for example, and we measure them in terms of the MCOs. Are they, in fact, making those contacts? Have they at least made the attempts? And so I think what I was trying to say is that rather than just looking at one place in the contract where we can try to improve this measure, we're looking at it from a variety of different angles and trying to raise that measure up. And so I guess I would say that it's not redundant, it's complementary. It's trying to weave together a series of aspects of the contract to improve that measure.
Thank you, sir.
And just to add, Representative Edwards, we did actually see an increase in this measure from the prior year of about 6%. So, and which would, I think, complement when we started to place a greater focus on it. Certainly is not where it needs to be, but we are seeing the right directionality that we're looking for.
Thank you.
Are you ready for the next slide?
Yes.
Are you okay if we move ahead?
Oh yeah, no, I'll keep interrupting if I have more questions. So.
No, please. And the breast cancer screening, just so you know, for that, that is where HEDIS uses percentage of women 50 to 74 years of age.
So there's not a set age, it's a range, and then they choose the range based on other diagnostic characteristics of the patient. I was expecting there to be one age where breast screening begins.
At 50, I think is what Patrick was.
Yeah, 50 to 74.
Oh, so we kind of stop at age 74.
Correct.
That
Okay, that, no, I know. And then is that once every 2 years, 3 years? What's the frequency once a woman gets started?
So it's following the U.S. Prevention Task Force recommendations. Receive a mammogram every 2 years.
All right. Good. Thank you.
Patrick, can you see the next slide?
Yes, absolutely. So we showed you sort of some of the key performance indicators that we do look at. When we did the quality strategy, updated our quality strategy, you see we compare a lot against the national average. Where our desire is to kind of start comparing New Hampshire against a higher bar. New England tends to be a healthier area of the nation. So we've started to look at how does New Hampshire compare in our rates, not only against the national average, but against the 75th percentile of Medicaid care plans in the state. So in doing this, we got together a group internally and found 10 measures where we were actually below the 75th percentile, and those were going to be some of our focus areas over the next 3 years to raise up to the 75th percentile. And where we look at those is we look at those in areas of prevention and treatment. You'll see some of the categories here, some that we've talked about before: adolescent health, women's health, adult mental health, children's mental health, substance use disorder, and one measure as well of appropriate care. So the link here goes to kind of that report. We'll kind of tell you a little bit more in depth of the different measures, but also how we've fared. We have after a year and a half of doing this work. Henry, do you want to jump to the results of that? So we're
Sure.
on topic. It's the slide, and then we'll come back to the External Quality Review Organization. All right. So what we have here is we've given you sort of where New Hampshire is in the baseline, which is the column NHCY 2018. And by CY, we mean calendar year 2018. Goes different than the state fiscal year. And then after publishing those 10 priority quality improvement priority areas, we have an update of calendar year 2019, how we've done. And then we have a color coding here, which will show you a range, particularly in calendar year 2019, how those results are. Red meaning still below the 75th percentile, but also below the 50th percentile as well. Areas would need more focus. Yellow being that the performance was still below the 75th, but we are higher than the national average at this point. The lighter green being that we had improvement from the prior year, but we're still below the 75th percentile. And then the darkest green meaning we've sort of achieved that goal. So you see the majority of the categories, there's 10 of them, we're showing you 5 here, have the light green where in the prior slide where we're improving, but not at the target yet. And then the next one shows that of these, almost all of them are at the 75th percentile, with one being still below the 75th and the 50th. So that's a lot of information at once. The
color coding helps a lot. So
Good.
If we could go back to the previous slide.
Sure.
Okay, so I think the color code is off in a couple of these boxes, if I'm reading your key correctly. But let's talk about immunizations. Two things. Is the HPV vaccine, is that settled science now where people think it's really a good idea. That's been out for about 20 years. Are we confident that's a good thing to be giving kids?
I think in terms of our measurement, we're following the National Committee for Quality.
I'm not talking about measurement. I'm talking
Okay.
about whether the HPV is good medicine. Are we convinced it's good medicine?
Well, I'm not a clinician, Representative Edwards. I think where we
That's
do.
fair. Then the other question is on these immunizations. For adolescents, I thought the last time I looked at an immunization schedule, it had, I don't know, 30, 40 vaccines that were sort of recommended. So what does it take to get a green in this area for a kid? They have to have the most critical immunizations or the whole panel?
So we have two different populations for child and adolescent immunizations. One is focused on the younger children, and that may be what I think perhaps what you're referencing, that has a far higher volume of immunizations. When you get to adolescents, it's really, I think, 3 or 4. And the most challenging of those is the HPV vaccination. I think it's still open for debate where the challenges are. I think part of it is that it's a 2-series set, and adolescent well visits. When you have adolescents, that you just aren't going to the doctor as much as you were with children in the earlier years. But if you can see the difference between these two adolescent vaccination measures, the first one, when you don't include the HPV, the rates are far higher than when you actually do include the HPV. So that first row you see has a 78.2% compliance rate, but then we drop down to 33.1 once we start evaluating members who also had the full HPV set. So if you had to say, I think to your point, I think it's the HPV where we're struggling.
Okay. All right, thank you. I don't see any questions from anyone else.
So I would just add here, Representative, was what we try to do is, as Patrick talked about, we're looking at up to several hundred different measures, but we wanted to, where we were not at the 75th percentile of performance, we wanted to identify 10 things to focus on for several years to raise them up. And, we wanted to show you that while there are certain areas where we've made that, there are other areas where a year or so into it, we still have more work to do. And again, I think, there are many good things to say about New Hampshire's Medicaid quality, but there are areas where we need to improve, and we're highlighting some of the priority areas here for you.
I like that. It's a huge program, and there's a saying something like, if you don't measure it, you're not going to fix it. So I'm glad you're doing this.
And we try to work with the MCOs to focus on this and all the different ways that the department's interacting with the public on these areas. We're trying to, leverage focus on this. So I think that's what we had for quality, and like to now, I think one part of the slide deck we were asked to address were sort of four areas where we feel like we've had some key accomplishments, and I think I'll start to drive again from here, Patrick, if that's okay. So I think in terms of things that we're sort of proud about from the Division of Medicaid Services is over this past year, certainly the response to the public health emergency. The Division of Medicaid Services has played a key role in it. I talked about earlier, during the public health emergency, if you follow the maintenance of effort requirements, a state is eligible for enhanced federal match. And you can see here for state fiscal year 20, that represented $22.8 million of additional funding. And for state fiscal year 21, we're expecting that to be another $45 million. I will stop here for a moment as to just mention that the length of the public health emergency has seemed to have some different perspectives on how long that would last. When we prepared the agency budget, as an instance, we thought it would end a lot earlier than it is. We didn't have the spike that we saw, from the Thanksgiving period through early February and then even into the governor's phase of the budget. It's since I think the top end of the spike that the federal government has anticipated based on the rollout of vaccine and the variants that there's an expectation that the public health emergency might last as long as the end of the year, calendar year 21, or maybe even longer. And so as we look at some of our numbers, as we move towards the next phase of the budget process, there'll be some updates to these numbers as we learn more definitively how long things are going to last in terms of the public health emergency. So as we get into this later, I'll repeat that I think again, but these were our best estimates at the time. Also at the beginning of the public health emergency, before provider relief money became available to our medical community, we were concerned about the sustainability of our safety net, and we renegotiated the MCO contract to not spend new money, but money that was already appropriated within the capitation payments to reallocate it to our safety net providers because utilization of services were down. And so that was, I think, an important early help to safety net providers, FQHCs. In another way, we were able to help the community mental health centers, home health agencies, all of our, what I'll call more subsistence agencies. In terms of the provider relief funds that did come in, the federal government depended on state Medicaid programs to provide information so they could figure out how to design it. And there's quite a bit of work that our MMIS team put together to make sure that the federal government had what they needed to give New Hampshire its fair share of that allocation. One of the big issues that we'll talk about later on a little bit more is that while we continue eligibility, there'll be a time when the public health emergency ends and there are issues in terms of, if you will, flexibilities the state of New Hampshire was able to acquire through waiver, as well as eligibility that we'll have to work through all that. And that's, we've been, if you will, standing up all the things that the opportunities that made sense for New Hampshire. And at some point we'll need to also unwind those things. And so we've been involved in standing up and planning for the ultimate end.
Am I interpreting that bullet correctly to think that there may be some providers that will be disenrolled?
No, this when we're talking about provider enrollment here, for example, at the very beginning of the public health emergency, if you remember, there was an executive order around telemedicine, and for example, New Hampshire depends a lot on, say, Children's Hospital to provide care for children, for those children in need. But in terms of getting them enrolled so that they could provide telemedicine services, we were able to get some flexibility to be able to enroll, if you will, the Boston medical community to be available to provide telemedicine services if that was needed. And so it allowed us to use, if someone was already enrolled in Medicare or in another state's Medicaid program, we'd be able to accept that enrollment, that eligibility for enrollment on a temporary basis during the public health emergency. Does that answer your question, Representative?
That's really great. It triggers a few others, but let's continue.
1135 is a section of the Social Security Act that deals with the waivers that typically come into play during a public health emergency, and one that we were able to help some families. There's been a real shortage out there, as you may have followed the news, that some of the people left the workforce in terms of for a variety of reasons, in terms of whether they be nurses or aides or LNAs, and family members who had to provide care for children in particular and adults, that it was hard to get workforce. They were concerned about bringing workforce into their home. What we've been able to do, leverage our existing 1135 waiver in personal care to allow us, where you can't get help, is to provide some compensation for families to provide services that would otherwise be delivered. For example, a family member may be involved in providing a service that a home health agency may have been providing earlier, or another agency that they can't, there's just no help available. And so this is providing for a certain number of families some temporary relief. This flexibility will go away after the public health emergency. But one of the things I think from a public policy standpoint is that after the public health emergency is over, that our workforce, whether it be nursing homes or hospitals or home care, there's been a reduction due to people leaving the workforce, and also the effect that education programs, training people, that we've lost some workforce here, and we're trying to work to see what flexibilities in the long term we'll be able to maybe bring to bear to help deal with what I think is going to be an upcoming shortage that will be very difficult to work for when meeting people's needs.
So expand on that word flexibilities. What are you thinking? Give me a couple of examples of what flexibilities you think we might need.
So as an example today, for private duty nursing that we provide for someone who might be, severely disabled, child at home, that there just aren't nurses available through agencies sometimes to do that. And in some states, for example, they allow individual nurses who get enrolled in the program to be able to provide those services. So it's basically opening up what might be available in terms of nursing coverage, that some people don't necessarily want to work for an agency. And so we're looking at that option. We're also looking at seeing if the federal government will work with us on extending this personal care opportunity. And when I say this opportunity, it's not just a willy-nilly thing that the individual has to go through a criminal background check and training and be seen to be capable of delivering that personal care. But is there a way outside of the 1135 authority, which ends the day of the end of the public health emergency, that we can structure some things? But it's kind of looking at, we have, as you can see, sort of in the area of telemedicine, we've opened up a lot more avenues for care to be delivered, and taking out some of the time to get to people. I think we need to look at how we can expand the existing workforce's ability to meet our beneficiaries' needs. And I think that we're also looking at nurse delegation under, and that may require us to work with the Office of Professional Licensure in terms of, can individuals who have received trainings, for example, like trach care as an example, is that something that would be able to be with a certain supervision and sign off, be something that someone could specialize in, as opposed to having to rely on a certain level of licensure to do that. And so these are the types of things that we're looking into, because we know that there's going to be an increasing shortage, that there are people who are not able to get all of the care that's assessed to be needed, and we're trying to figure out ways to be creative to work around that.
So I assume your internal procedure is that when you come up with flexibility ideas that require, you figure out if a New Hampshire statute needs to be modified, and in which case you work with Mr. Williams, who then in turn works with the Senate or House HHS. Is that your normal process? Yes,
and also with other bodies. A good example of that is what we'll talk a little bit about later, is in the Medicaid schools area, in terms of trying to get last session, just before the pandemic kicked in, was Senate Bill 684, which provided licensure for school psychologists so that they could bill Medicaid. And also master's prepared people brought them under the Board of Psychology. Excuse me, I need to take a drink. So we do have to work with John as well as other agencies and the legislature, of course, as well.
Yeah. So in this budget, do you have any requests for funding to help with any of these manpower flexibility pilot projects? Or if you had a pilot project you wanted to try and you needed money, where would you get it?
I guess in terms of if care is not being delivered, that is been assessed as being needed, that would create some flexibility for us to be creative where we wouldn't need new money to do something like that. For example, if private duty nursing shortage, it would just basically moving from one bucket to another. Some of the other things that would require legislative changes, I think would probably be things that we'd have to work into next session.
Okay. Thank you.
We also took advantage of the federal government provided states the ability to create a new eligibility group to do COVID testing. It was basically provided 100% federal match. And early on in the pandemic, in terms of increasing our testing levels, so we had some sense of what the incidence of the disease was in the state, that this was helpful to that. Today, we have just under 7,000 individuals who are in this testing group. This testing group would end at the end of the public health emergency. There is federal legislation that may extend this for a longer period of time. We'll see what comes out of the latest legislation when it goes through both the Senate and the House. This basically provided for testing and some limited diagnostics around it to ascertain whether someone had COVID or not. And then we were also involved in the execution of the expanded telehealth from a Medicaid perspective in terms of getting the executive order implemented, as well as working on the rules as they affect Medicaid with respect to legislation that was passed last session on telehealth.
Who is the lead person in DHHS who's the most knowledgeable about DHH efforts to support telehealth?
So Dr. Ballard, who's our medical director, is, and Jane Hips, who heads our medical unit, are the two individuals that are involved at a legislative level on the committees that are working on the telehealth rule. I think Dr. Ballard certainly from the physician perspective in terms of how it can be used, and Jane from basically the licensure and Medicaid rules.
Could you send me their contact information, please?
Absolutely. Just to make it.
Thank you.
Very good. So one of the things that the department does is implement legislative policy and federal regulations and state regulations. I talked about the top bullet here, which is the Medicaid to Schools program, which school psychologist was one of the most important things, but there were other aspects of that legislation that helped speech therapy, that helped administration of medication in schools. We've also worked in HB4 in 2019, an adult dental benefit design was passed, and then there's been legislation. There's two bills actively being considered right now in terms of financing an adult dental benefit. And we work with a stakeholder group and actuaries to help shape and design that.
So I want to stop and talk about this a little bit more, because
Sure.
You came in and you gave us a special review of the dental program, and I got to tell you, I forgot some of the key stuff, but I have an email from the governor's office who it makes it sound like there is no dental care program in Medicaid in this budget at all, and that he cited that that the governor vetoed HB 250 in 2020, which would have established the program. And so what I'm confused about is there a legal authorized program or not? It's a yes or no.
Yes. And it
What's
needs,
the source of the authority?
so
HB4?
HB4 in 2019, the issue is that while there's a benefit, there's not adequate funding to do so. And really, 250 last year and the two bills this year are really about, providing both the funding and the benefit design that would be more economical to implement. I think the governor vetoed 250 based on cost, and the two bills have a more economical approach to them than what was in 250 last year. There's also, to my understanding, in the Senate, a timing issue that's being looked at in terms of trying to minimize the cost in this upcoming biennium and to start the program. And I do know that in the governor's inaugural address, he talked about this as being an area that there might be an opportunity to work with the legislature on. From a standpoint of need, the need is there. I think, ultimately whether it goes forward or not is a decision of the legislature and the governor, but we have a requirement under HB4 to be doing this work.
So I'm thinking about what you just said. So it sounds like there are two bills currently before the legislature to take the authority of HB4 and to shape it a little further and to fund it. Is that accurate?
I think that's a fair overall assessment of it. There may be other people like John Williams who could give you a more technical explanation, but I think that's a fair characterization of it.
Okay, so that would be another one of my questions. Could you tell me the two bill numbers so I can go look at them and figure out where it is in the committee process, please?
Senate Bill 150, which passed the committee, the Health and Human Services Committee unanimously. And my understanding is that that's the bill that is considered a date further out, I think January of 22 beginning, which would change the date that was in HB4, right? And then there's House Bill, I believe it's 103. Both those bills are in hearings this week, to my understanding. I also have Dr. Finney, if you want to get into this a little bit further, who's, I believe, out there who could be brought in to give you a little bit more update than I just did right now, if you'd like that.
No, that's sufficient. I just needed to be reminded of what I'd forgotten, and you did that. So thank you.
We also had sent something to Kevin Ripple. I don't know, Kevin, if that has been able to be distributed yet. I think it was just sent to you probably end of the week. Just some notes from the meeting that we did have.
I think that exact document, though, on our website hasn't been emailed out, although that information was contained in a separate email I sent. I had linked to the House Bill 103 or the Senate Bill 150 fiscal note, I'm not sure which. So it contained the same financial information as in the document you emailed last week.
Good, thank you. So I think those two things give you the background that can be given. I think right now we're really at the discretion of what the legislature and the governor is willing to do in this area.
I think it's generally good healthcare to take care of people's mouths, and that it saves money in the long run. The issue is what's the right size, I think.
Right. Another area that has to do with sort of federal compliance. The federal government asked the state to document beyond what's in statute how the intergovernmental transfers that fund the county cap, and to put that into sort of a written agreement form. We were able to complete a document that addressed the federal government's concerns to put something into writing beyond what's in our state statutes. We worked with the counties and coming up with something that was acceptable to them. In terms of state plan amendments, there was a lot of legislative activity that came out of the last session, probably double the amount of state plan amendments that we had to execute on. And we had to do that at a time of both a public health emergency as well as losing one of our key staff who works in this role. And so I'm proud of the team stepping up and making sure that the work got done at a time, double the work with a key individual wasn't able to be there the whole time for us. We also, I'm sorry, see Representative Earth has a question.
Oh, yeah, he does. Go ahead.
Thank you, Mr. Chairman. Can we get a copy of the intergovernmental transfer agreement you were referring to between the state and the counties?
Sure. We can do that.
Thank you.
And then the last two bullets on the page are policy that was passed again in a prior legislative session, implementing the Medicaid for older adults with disabilities and expanding the MEAD. These basically are programs that help people with disabilities to be able to participate in the workforce without losing benefits and as a result of earning some additional income, the benefits of being able to be engaged in your community without the risk of losing benefits with a little bit of additional income is kind of the key thing here. MEAD is for people who are less than 64 and less, and MODE is for adults greater. In MEAD, we also updated the financial eligibility requirements there, and we'll talk about a little bit that when we get into some of the prioritized needs that weren't necessarily funded in the budget so far.
So one of Representative Weiler's not here, but one of the things he emphasizes in this is that if you know that the federal government has changed eligibilities, or that we're planning on changing eligibilities in a way in which it increases our financial obligations, that you're letting us know in a formal, direct, clear communication what those eligibilities are and what your anticipated impact will be.
Right. We did do through our fiscal notes and with the legislation. It's just that the funding didn't end up following through, and we didn't have control of that ultimately.
So I'm talking in general for
sure.
all programs, with all of them having eligibilities. If the eligibilities change in a way in which it's going to cost more money or save us money, you're letting us know on all of them, I assume.
Yes, and by statute, there are certain things that we have to take through various committees of the legislature in order to even submit a state plan on those.
All right, thank you.
The next slide, in terms of program development, one of the major areas of focus that we work on is a major part of funding for the department comes from the Medicaid Enhancement Tax and the disproportionate share payments that we make to hospitals. And basically in 2018, there was a legislation passed in HB 1817 to put together an agreement between the state and the providers, and the rules that have to be followed there are governed by both state and federal authority changes. And as those things change, we have to work to modify the program to continue its compliance. We also have reporting obligations, which we work with the Medicaid Finance Unit and complying with the Granted Advantage program. I heard before the meeting started that there's a committee that some of you may be participating on in terms of evaluating the Granted Advantage program. And those are the types of things that we would help provides information to the committee on. Non-emergency medical transportation is an area that as part of the recent reprocurement was bid out differently than it had been historically, and implemented that. And I'm also proud to say that our team, Brooke Belanger in particular, supported the EOC in standing up in less than 2 weeks' time the transportation to support the non-Medicaid individuals in the state who otherwise wouldn't be able to have transportation to get vaccinated. And that program kicked off this weekend in particular. MMIS is an area that we'll spend some more time with, but for most of this past fiscal year, we've operated with some significant staff vacancies, and we'll talk about that more later. And then lastly on this slide is operationalizing the maternal opiate misuse model grant that we received. This was in support of Manchester medical community coming to the state to help them be eligible to apply for 2 grants. And these have both recently gone through both fiscal committee and governor and council. We had a delay because of the COVID-19 situation. The first people that will be enrolled in this will be in July, but basically the idea is to support moms and the care of their children who may be addicted to opioids. I see Representative, you have a question, Representative?
Yeah, Representative Irv.
Thank you, Mr. Chairman. Since you're on this topic, since you mentioned it, can you remind me what the source of funds is for the Granted Advantage program?
Sure. In the Granted Advantage program, the federal government kicks in 90%. Then there is 10% non-federal share. And really that non-federal share component, the 10%, is derived from several sources. The premium taxes on the policies themselves is one source. 5% of gross liquor profits is another source. And the third source is the New Hampshire Health Plan, which historically was the high-risk pool, that they contribute amount up to what those other 2 sources generate. So the liquor fund 5% and the premium tax that those monies are kicked in to come up with a 10%. There was also legislation passed last session if that wasn't sufficient, that additional liquor funds could be accessed. And that turned out to be timely from the standpoint of the surge in enrollment as a result of the public health emergency. But that should back off when enrollment goes back to historic levels.
Do you happen to know the RSA that specifies all of that?
I do. And just to make sure I give it to you correctly, I'll ask Athena if Gagnon to make sure to maybe if we could bring her on if she has it, but I think it's RSA 126 AA3 is where you'll find that. Athena, can you correct me if I'm not? I'll verify that. And,
thank you.
Okay.
So just so you know, Mr. Lippman, we're gonna break for lunch when we're through with your slides. So
okay.
If anyone's getting hungry, they can blame you at this point.
In terms of the challenges facing the department, so the public health emergency and how long that's going to last creates a lot of uncertainty in terms of predicting impacts. Then as we'll talk about a little bit more later, we have substantial vacancies that we've been contending with while at the same time expanding the scope of work that we need to do. And then lastly, in terms of the unwind of the public health emergency, if we want to keep those people who are eligible enrolled as the public health emergency unwinds, but those people who aren't eligible, we also need to disenroll those people who aren't eligible any further at the end of the public health emergency, because it costs $500 roughly per person per month. And if you had 20,000 people who weren't eligible, as an example, I'm not saying that's the number, but if you did, that's like $10 million of expense, total funds. And so it's important that we work to what I describe as avoiding a tsunami at the end of the public health emergency, of working through enrollment and eligibility issues that we're working that all along the way. And so that's one area that we're spending, we've been planning and working on for many, many months now. And is a high priority to make sure that we operate within the budget allocations. In terms of some workload things, it's currently in terms of Medicaid staffing today, we have 19 staff in the Division of Medicaid Services, and fully staffed, including what was in the governor's budget, including the temporary positions, would be 35. And based on that, you can see where we have some holes, and we'll talk about those a little bit. In terms of beneficiaries, typical thing that is looked at is a ratio of beneficiaries to staff. Today we're operating at over 11,000 beneficiaries to Division of Medicaid staff. If we were fully staffed, we'd be operating at almost half of that. Now you ask, how does that compare to the rest of the world? I think you can find that New Hampshire is probably on the upper end of staff, meaning that we have less staff compared to beneficiaries. But it's a hard statistic to compare, because how a Department of Health and Human Services is organized in a different state. Like for example, the state of Vermont is organized as a fee-for-service program, and they may have for example, their Division of Finance may be combined with their Division of Medicaid. In our Department of Health and Human Services, legal and finance are organized under their respective, if you will, expert areas, so that all the finance people are under a finance department, which I think makes the most sense, to make sure that the right supervision and quality is there. But this just gives you a little bit of sense that we've been dealing with some vacancies. We talked about earlier in this middle slide here that.
Before you hit the middle slide, Representative Irf had a question.
Sure.
Just a quick one. I'm having a hard time keeping up with that. I apologize for that. A couple slides ago, the Medicaid Managed Care Program, you mentioned two things about provider rates. December 2019, you implemented a 3.1% increase, and then the first of this year, I guess.
Yes.
Implemented another one. So is that basically 6% over time, or are those going to different groups, and it's 3.1% to different groups?
So the legislation that was passed was across the board for providers, a 3.1% increase. So it affected nursing homes, home health care providers, community mental health centers, FQHCs, hospitals, doctors, psychologists, all different areas of the department. That we have 30,000 providers that are enrolled in the Medicaid program, and all the different categories of providers receive some type of rate increase if they were a licensed or supervised by a licensed medical provider.
So those are two sequential increases, one
yes,
around one just this year.
Right.
Thank you very much.
And before you get on that, I want to jump to the end. So to keep moving, our MMS, MMIS, I think you said we have 100% vacancy in this area.
Yes.
So what are you doing to maintain the systems, and what's getting in the way of recruiting people to manage this system?
So if I could take the last one first, there was a hiring freeze was one aspect in terms of being able to recruit them. Recently, we've been authorized to hire for the positions that are available. We operate this system in collaboration with the Department of IT, DOIT. And so in terms of, if you will, the hardware and maybe it might be a good time to bring in David Wieters, but basically there's, if you will, the technical performance of the system, and then there's, if you will, the applications. It's really the application and business development side of things that we were tremendously shorthanded in. We've had one vendor consultant that we've been using to try to keep us afloat in this time period of the hiring freeze and so forth. But we were, if you will, underfunded last budget appropriation. We've had to find funds within the department to try to maintain it. We will talk about in a moment that we had risks around the federal match percentage. But if you're okay with it, I think if you want to get into MMIS, the next two slides I think would be good ones to dive into it. And David, I'd like to take the lead on that if you're okay with that, Jim.
Yeah, before we get going, Representative Wallner had a question, I think, on this slide.
Well, no, actually it goes back to what Representative Erf was asking about the rate increase that was in the previous budget. Previous budget, is there any rate increase for providers in this budget for the next 2 years?
There is not. In the division that I oversee there, I believe you'll see in LTSS, there may be some rate increases there.
Okay, but none for 2 years. And actually they will have gone, since the last rate increase was what, January of 21? Is that correct?
Yes.
So they will have gone 27 months at least before there would be any sort of rate increases for these services.
Yes.
Thank you.
Representative Wallner, I'm curious why you didn't ask if they'd requested it and the governor's office didn't fund it. That sounds like a normal question you asked.
I guess I was just a little asleep at the wheel. Like, okay, Mr. Lippman, did you request a rate increase?
We did not, based on funding what we already had in place. That it was particularly at the time we were preparing the agency budget and the shortfalls that were forecasted for the state, that practically maintaining what we had was going to be a stretch.
Thank you.
Thank you. We can, I'm sorry to just go skim over your second slide, but I think we can read it and it's kind of self-explanatory. So we can go to 26. Okay.
I think this would be, our plan was to have David lead this, and I'll add some commentary as he goes through those two slides.
Okay. You minimize your slide just a little bit because the way it's zoomed now, it exceeds the screen. There you go.
Okay, sorry about that. Thank you for letting me know.
Good morning, Mr. Chair and members of the committee. My name is David Wieters. I'm the Information Services Director for Health and Human Services. And our goal was to go dive into the Medicaid Management Information System, the current state, and where we're going with the system in this next biennium. Please let me know, and I'm aware of the process for questions. So Representative Edwards, Mr. Chair, I will recognize you waving your hand as you go through.
Thank you.
So this system has gone through what we call an application lifecycle management over the last 16 years. So back in 2005, we identified the system design of how we wanted to implement the MMIS system. We worked with the Center for Medicare and Medicaid Services for that system design and went out to RFP and initially purchased the hardware and software in 2007 after award. That was the last time that we actually acquired hardware and software up until this past year, where we did acquire some hardware and some software associated with what we call a technical stack upgrade. That capital project was funded at about $26 million of the original $90 million that we requested to manage the system. In 2013, we went live with the system, 6 years after procuring the hardware and software. Due to many different reasons, the original design was for a fee-for-service solution. Over time, we migrated to a managed care in this state, which required lots of changes along the way, as well as federal and state mandates that required some changes in the system. And of course, the final complexity of it as well. 2 years later, in 2015, the system was certified. And certification is a key component for our federal matching dollars as it relates to our maintenance and operations of these systems. So prior to being certified, we had a 50% match for the maintenance and operations. After certification, we received additional 25%, which equates to about $6.6 million in federal matching funds, reducing our general fund impact by that amount. As we have heard recently, this system is our core system to process Medicaid claims, provider services. It also includes third-party liability components from our other division for quality and program integrity, as well as does the basic functions of mailroom processing of reports and call center functionality for the provider system. When you look at this, yes,
I thought you were about to go to the next slide. Go ahead.
I'll try to speak up.
I have a question on this slide before you go to the next one.
Certainly. So just from an overall perspective, our current contract expires this June, and we're anticipating an extension of that contract for 5 years to support our reprocurement efforts. So this system, based off of researching different types of reprocurement strategies and working with other states within the country, as well as looking at different functions of leveraging the National Association of State Procurement Officers or looking at regionalized government to reduce our costs, we've identified a 5-year plan to replace this system through a modular reprocurement. CMS, or Center for Medicare and Medicaid Services, has a recommendation that we would do a modular reprocurement and has supported many other states in that effort. That 5-year plan requires us to maintain our existing system. And so in the operating budget that you're looking at today, that actually shows the increased cost to maintain the existing system, as well as ensure that we're not seeing a spike in hardware and software purchases throughout the time period. The goal of that is to really flatten that investment in the MMIS, the current MMIS system, and not have any surprises when it comes to hardware and software going forward. I'll go ahead and stop there on this slide for any questions.
So thanks. My question there is, over this next 5-year cycle, will some of the MMIS functionality be able to move to a software as a service model to get us less in the hardware business?
That's a very good question, Mr. Chair. Certainly our goal is to look at software as a service modules as they come available. For instance, the provider services module that the National Association of State Procurement Officers did a fairly large multi-state bidding process that we could use as a participating agreement, awarded to 6 different vendors, of which 2 or more of them provide software service solutions. Some of them still host their own server and software in their own call center, which you could consider a private cloud, but not necessarily the software as a service that you're looking for. All of our future ones would be looking at a subscription type software as a service module.
And I'm not a fan of the regionalized government approach, but it doesn't sound like that's one you've considered. You're just not going that way.
That is correct, Mr. Chair. Currently, when we looked at the regionalized government, it required a lot of either one of 2 different things. And so you need normally have a lead agency and following agencies, or lead state and following states. The lead state has a large investment in.
No, that's all right. If we're not going to do it, we don't need to spend time on it, but
Okay.
thank you. I don't see any other questions on this slide.
We can go to the next slide. So as I discussed earlier, the MMIS is a very complex system. It composes several different modules, which you see across the top of your slide there. Those are just the high level modules. There are several other modules included in the MMIS, but the core of the system is a claims processing system. We look at this and we get our direction primarily from state and federal legislation, and we need to address our 5-year plan in terms of the priorities. Our current priorities right now is to be able to maintain our federal reporting, address some of our pain points in provider services and call center management, as well as go into what you heard maybe last week, I believe, third-party liability module. I'm going to kick it over to Henry briefly to go over some of the key benefits of this system, and then we'll.
I have a technical question before you give it to Mr. Lippman. So historically, the concept of departmental systems was essential because that's how we grew our IT. We had a specific departmental need, and we solved it. Increasingly, I think the model is intended to be modular at the enterprise level. So as I'm looking at these modules, I'm seeing a call center and federal reporting and maybe training and communications as names of modules that could potentially become enterprise level modules. So because all departments have to do some level of federal reporting, for example. So my question is kind of a strategic one, in the sense that when you're looking at replacing the MMIS with a more modular SaaS model, I assume you're also looking at more of an enterprise concept than a departmental concept. Could you speak to that?
Thank you, Mr. Chair. That's a good question. It actually falls into our strategic plan that we're working on with Department of Information Technology, and leveraging platforms to not only address the Medicaid, but also other parts of our division and potentially other parts of our state. We actually plan on doing that kind of platform approach in the federal reporting, certainly, which we already started about 3 years ago, building our enterprise business intelligence platform, but we have not had a chance to fully integrate or basically take out of the MMIS that component. The next 5 years, our goal is to take that component out and leverage that enterprise business intelligence platform that spans our entire department, as well as our partner agencies within the state, and then continue that process of looking at certainly call center training, communications was another one. And then the final one that we believe that we could leverage enterprise approach is the claims processing. We process claims in our children, youth, and family system, our long-term supports and services, our child support, as well as on our Medicaid. And we believe that we can leverage that one claims engine with 4 different, what we call business rules and processes from one vendor, which will reduce our footprint of systems over time. Does that address your question, Mr. Chair?
I love the concept, and hopefully you guys will continue to work on that in the strategic plan. So I think that's going to give us the best solution at the least cost and the greatest simplicity over time. So hopefully that vision pans out.
We agree, and we are also hopeful for that vision to pan out. We've seen quite a bit of effort in improved data quality in leveraging the enterprise approach for the enterprise business intelligence, and we anticipate it to continue to enhance the Medicaid program by doing that, as well as other modules throughout this project.
I don't see any other questions on this slide, so unless you've got something you want to say, you can continue or give to Mr.
I would
Lippman.
like to, if I could, Chairman, just on the right side, the penalty and risk, is that what we're pointing out here is that without funding, we would end up with a system situation where we're going to pay penalties that are equal to the cost of what we need to implement that we haven't been able to implement due to lack of funding. And also, in terms of your constituent services, if you will, that 30,000 providers and 215,000 citizens depend on this system in one way or another. And I think that I think the point we're trying to make here on the right-hand side is that without adequate funding, we're going to end up running the risk of we're going to have to come up with general funds of somewhere around 6.6 million over the biennium, as well as have a system that potentially could lose its compliance status, and that would cost us 25% federal match.
So I need you to be a little more clear with me. Are you saying that you need money that's not in the governor's budget and we have to add it?
No, the money is in the governor's budget. We last biennium, we were not funded for projects that we know that we needed. And as a result of that, the time frame to implement things, we're not going to make those time frames. And without approving what's in the governor's budget, we'll be at risk of financial penalties that are equal to or greater than what the cost would be in general funds if the governor's budget is funded. We're saying that the governor's budget funding is very important.
So you're also then saying that in the FY21 budget, if we were to freeze your funding at FY21 levels, you would not have enough money to cover this.
Absolutely. We would probably also run the risk of losing certification and take a 25% cut in the federal funding.
So that's good to know. Would you just send me a little note of specifically what line item this is and what the change is from FY21 to 22, so I don't lose it? Or is that it in the slide?
The bottom left-hand side, I think when we go through the line by line, it will be fairly evident where it is. And if after that you still need something, I'll certainly provide it for you.
So I'm still learning to swing through the budget. I know that I need an accounting unit line number somewhere to make sure that I'm tracing the right account.
I'm going to make myself a note so that when we get to that point and Karen's going over things, that we cover that line or those lines. If it's okay, I can continue.
Yes. I don't see any questions.
I think Athena was going to, Athena Gagnon, our Director of Medicaid Finance, was going to help address this slide. Athena, if you would speak to this.
Morning. So the first item that I'm going to cover here is what we spoke about earlier, and that's the funding the adult dental program. We do have a priority need. We have a new request in the House where I'm actually lowering the priority need in fiscal year 22 due to the change in the proposed implementation date of April 1 as opposed to an implementation date of September 1 of 22. The other priority need that we need to actually revisit is funding the increased cost of the pre-COVID enrollment if we don't reach it until March of 2022. As Henry Littman mentioned earlier, when we built the budget in August, we were actually anticipating that our enrollment would be at pre-COVID levels by July 1 of 2021. New indications, of course, with the rollout of the vaccination and the second surge that we saw during the holiday season, we are anticipating in the governor's budget that the public health emergency period will end in December of 2021, which would allow us 90 days to disenroll those members, and we would reach pre-COVID levels by March of 2022. The third item that we also need funding for, again, is something that Mr. Littman mentioned earlier, and that is in relation to the MEAD program and funding the in and out. And that priority need in total funds and general funds is listed below. If we were to decrease our budget, there are some items that are listed that are obviously not recommended, but they would be eliminating coverage for the optional eligibility groups. We could not make any changes to those until after the public health emergency period. Same goes for optional covered services, the top three being pharmacy, home and community-based services, and community mental health centers. Those are all listed in the briefing book on pages 70 and 71. And then also just mentioned earlier is the risk if the MMIS is not funded, we risk certification, which David Wieters mentioned would be a general fund impact of 6.6 million annually.
I guess I would emphasize that these are things that we're not recommending, but in terms of trying to reduce based on the requirements of what a mandatory service is, there's not a lot of room to do things other than things that really would have a negative effect on many citizens of the state.
If you were to recommend reducing your budget, you would be the first director, I think, in U.S. history to ever have done that. So we're not breaking ground on that today. Hey, but I did want to say this is the about the 8th or 9th time we've seen a slide like this, and this is really the most developed. So thank you. It's the most useful as a result.
Athena, I'm fortunate to have an excellent finance director, and working with Athena, very experienced. And on the next slide, kind of shows the team that's within the division. Well, Athena is technically in the finance division. She's a key player to making the Division of Medicaid Services work in terms of budget and policy issues that require money. Is the size of the slide okay? Can you see this okay, Chairman?
Oh yeah, that's great. Perfect
So,
on my end.
so just in terms of the team, I'm fortunate to have a lot of good people that have been able to and willing to step up and do go above and beyond dealing with a lot of the vacancy issues that we've had. There's my role as the director, and again, consultative to many other divisions and supporting team, if you will. It's as I say, Medicaid is definitely a team sport in terms of both within the division and within the Department of Health and Human Services. You've met Dr. Finney, who is our dental director, is a licensed dentist. We have a position called the Director of Medicaid Enterprise Development, which is Brooke Belanger. Brooke comes to the department having at one point in her career been head of the Medicaid fraud unit for the Attorney General's office, and had worked as a compliance officer for a major health system in New Hampshire. She's a lawyer by background, but her role is trying to make sure all the different, if you will, silos or pieces of the Medicaid system sort of are harmonized so that things work the way they're supposed to. We work with, Meredith Tellis's unit as well in terms of program integrity. And Elisa Cohen is my deputy. She's been here 2 years, came in originally on the Granted Advantage Healthcare Program waiver, and she's going to be the deputy. She helps me in a lot of areas of running the entire unit. Elisa comes to us with a policy background, having worked in New York State government, actually in the city of New York, and working for a large health system. Then underneath that, we have Mco Operations on the left here, Shirley Capino, who's been with the department 5 years. She and Laura Ringelberg run our Mco Operations. Again, they help coordinate and supervise day-to-day activities within the Mco program. Jane Hips, who is our clinical lead. Again, she operates, she's a nurse by training. She's my most senior person in the department. She oversees the clinical aspects of the Medicaid school program. She oversees prior authorizations in parts of in the FIFA service side of state plan services. She's a consultant on clinical issues that come up around the MCO operations in terms of working out, for example, when we were going to handle the public health emergency in terms of prior authorizations and things like that, how to harmonize that so we would have the least impact on providers when they were tremendously stressed, as well as making sure it worked for our beneficiaries. Don Landry, who's been with us 28 years, oversees the policy unit, oversees the state plan work. We had someone who retired, who had been with us over 40 years, who oversaw a state plan, and she's helped fill in that gap tremendously during this time. But all the eligibility rules and regulations, which they're feet thick, if you will, in terms of what we have to comply with. Dawn is our lead on that. We also have a pharmacy director. We have two pharmacists, Peg Clifford and Lise Ferran works with her, both long tenured people in the department that oversee our pharmacy benefits. The state in the most recent procurement went to what we call a single pharmacy drug list, pharmaceutical drug list, and that's a recommended practice to help with pharmacy costs from a financial standpoint, as well as from a rebate standpoint, and helping improve that for the state. We had a director of provider relations, which we person retired during early 2020, and that position again helps us interface with 30,000 providers. We actually have 2 vacancies currently in that unit, and Brooke Belanger has been helping fill in some of that role. We also have an administrator of our federal waivers, in which that position is also vacant. And then we talked about MMIS, where all these positions are currently vacant, and we have, again, 1 consultant and the support of DOIT, who's gone above and beyond to keep us functioning during this time. I don't know if there are any questions on the organizational structure here and the people.
I have one.
Sure.
So in the military, we made a distinction between faces and spaces. A space was just the head count and the line item, and the face was the actual person. And so I do not want to talk about the person. I just want to talk about the position.
Sure.
The dental director position, if we've not had a Medicaid dental program, what drove the need to have a dental director position, and is it a full-time position?
Well, we cover over 90,000 children in a dental program. If you remember, what we're asking for approval for is an adult dental benefit.
All right.
So
You did it. Thanks. Representative Weiler's back now. Thank you, sir. All right, we can continue.
So this slide, let me make sure you can see it okay.
No, it's good.
Okay. Basically, the left-hand side is the list of positions in the governor's budget. There's also 2 temporary positions, which are footnoted in the MMIS areas temporary. The next column is our vacancies, and then the vacancy rate in those positions, and then just kind of the general description of kind of where they fit under our Medicaid Services Administrative Accounting Unit.
Okay.
Just suffice it to say, the MMIS hole is very important to fill, and we're struggling with the in the clinical area and the provider relations area in particular with the workload and rolling out new benefits and having fewer people and greater enrollment. So these are, I think, are very important positions. I think the governor saw it as well in his proposed budget.
Well, if you pay more than 100 a year, I'll start Monday.
And Henry, could I just jump in there for a half a second?
Please, Karen.
So one of the things I wanted to mention, Chair, and I know that the report is outstanding still, and as soon as it is public, I will have it to the committee. But one of the things that Alvarez and Marcel looked at was staffing across the department, but especially staffing in Medicaid, and comparing it to some of our neighboring states. And compared to some of our neighboring states, we most certainly run leaner in our Medicaid department. So that's just something of note.
And speaking of the M&A report, what's the most current estimate for when we can get our first secret copy of it?
So unfortunately, I can't provide you a secret copy of it. I will provide you the document as soon as it is public. I don't want to promise you a date and then not meet it. I really don't like to do that. I hope it'll be this week, but I don't have a date certain for you.
I think, Karen, you were going to pick up from here? Or is it, am I right on that? Or Athena, are you addressing this next slide?
I don't see Athena unmuting, so I'll go ahead and just speak to it. Of course, Medicaid budget is one of our largest budgets. So although this chart lays out all of the information, I don't know that it's the most helpful to see it this way. I think looking at each of the accounting units is probably going to be a lot more helpful, but this does give you a little bit of sense of the overall budget.
What's the overall issue between the expansion of general funds in the current budget and the reduction in general funds in the next budget? What's just the general story, the one sentence?
So the general funds are actually increasing. They're the red piece of the chart. I would say half of that is related to the DCYF costs coming over into the Medicaid budget, at least half, if not more. Somewhere in that range. But you'll see more of that as we go through the actual budget.
And the federal matching percentage changing.
Right, right, and the federal matching percentage changing, yes.
Just in terms of federal matching, this is just a reference slide for you in terms of, you know, how the federal match is determined nationally has to do with per capita incomes. And so we said earlier in the presentation that New Hampshire's minimum is 50%. But some states like, you know, Mississippi comes to mind, you know, that are the poorer states get a higher match. And that's just, there's nothing we can do about that. It's a statutory thing at a federal level.
So Mississippi has a higher proportion of federal money to state money because of their higher need. Is that what you just said?
Correct. Their poverty in particular, you can see the Northeast tends to be lighter in terms of you know, New Hampshire's has poverty that needs to be addressed for sure, but you know, relatively, we're compared to the rest of the country, you know, we're economically, as is Massachusetts, Connecticut, Rhode Island, in better shape. And we put together a slide. Again, this is sort of a reference slide for you in terms of the different federal matching rates at different time periods. If you'd like us to dive into this a little bit, be willing to do so, but I just wanted to give you something here in the interest of time that shows how the federal matching rate changes under the enhancement and how the enhancement changes over time.
Representative Earp has a question.
Sure.
Thank you, Mr. Chairman. Can you speak to how you intend to share the benefit of the enhanced federal match with the Medicaid providers, in particular the counties and all the county lines, not just the nursing home line?
So I guess the short answer is it's not a simple response. I think as you know, because you serve on it, there's a county and state finance committee that's looking at it with respect to the county cap. But the intent of the enhanced FMAP is to cover the expanded population. We have, as I mentioned earlier, you know, a 21.5% increase in total enrollment, and that comes with some cost. And so that, you know, in terms of covering the increased enrollment, the published studies on this, for example, the Kaiser Foundation does not expect, at least to this point, the enhanced FMAP to cover states' costs in total in terms of the expanded enrollment and the expanded utilization. I think I'll let Karen maybe add to that explanation if she would like to, but I think generally the enhanced FMAP is intended to cover the expanded population that you have to cover, and is also sort of the, you know, at the time that it ends, the public health emergency ends, we're obligated to provide coverage to the end of that month, and I think that's kind of the story to this point. There could be, I think over time, you know, we've identified, for example, in the county area that, you know, there is by statute a percentage that the counties are responsible for if the FMAP goes on for a certain amount of time, that there would potentially become a credit available. I know there are other discussions there that I don't want to get ahead of. But I think in general that the additional FMAP is intended to cover the additional enrollment. And again, that for many states, the additional FMAP might not cover all the additional enrollment costs.
Thank you.
No, Karen, if you want to add to that at all.
I guess the only thing I would add is that the county funds are not in the Medicaid budget. They're in the long-term supports and services budget, which we will cover hopefully later this afternoon.
Can I just ask a follow-up?
Yes, sir. Go ahead.
So, yeah, no, thank you. I'm just trying to form the question. So they are Medicaid services or no?
Yes, it is Medicaid, but because they're for long-term supports, like nursing facilities, we do have that within the long-term supports budget, as well as like the DD budget is also Medicaid. It's a Medicaid waiver, and that is in with the long-term supports and services budget. If we lumped that all into one budget, more than half of DHHS's budget would be in one place.
There are 16 county units that have some level of Medicaid participation. That's what I was speaking at the beginning, that we both run a program and provide support to other divisions of the department to be able to draw Medicaid funds to support their programs.
So just so I understand what you're saying, the Medicaid component actually shows up in many different budgets. It doesn't necessarily say Medicaid with it.
Karen, I'm not sure how the different units designate the Medicaid component in their budgets, but so I might let you or Athena answer that part of the question.
Sure. So as far as Medicaid services, like paying a provider, for the most part, that is in the Medicaid budget and in the long-term supports and services budget. There might be a little bit in other areas of the department, but that was, as we spoke about, moving the DCYF Medicaid cost into standard Medicaid, that was part of trying to consolidate that. When it comes to Medicaid administration, that is probably in 75% of the accounting units across the department, right? My salary is partially paid with Medicaid administration, the commissioners is, et cetera, et cetera. But as far as paying providers, for the most part, it's in those two budgets.
Thank you.
Is that it, Representative Urf? It sounds like you're satisfied.
Yes, thank you,
Okay.
Mr. Chairman.
All right, so we can go on. And just, I want to give a heads up to the folks who are listening in, the attendees. I see several of you who are expected guests on Wednesday afternoon. I'm looking forward to talking to you then. If there's any attendee that has a short comment to make to help the committee make some of these decisions we have to make, you'll get an opportunity here in a moment to raise your hand, and I'd like you to keep it short if you do have something to say. All right, so go ahead. Sorry for the interruption, and I think we're ready to close out.
So the last two slides are really the the detail I think you're looking to walk through after you have your lunch break, which is the unit by unit, line by line items. And I think we've done, I think, with what we needed to share with you, unless there are further questions on the prior slides.
I just have a general question, and we will dive into the details, but the IDN fund,
Yes.
what do we think we're buying with an IDN fund?
So in the new budget, there's no money in the budget for that in terms of the reason that's still in there is because of the history aspect of it. And so there are 0 funds requested and 0 funds appropriated in the governor's budget for 22-23. The waiver ended December 31st of 21. There is a run out period that runs through the state fiscal year 21, but there won't be expenses in 22 and 23.
All right. Are there any questions at this point? Okay. Are there anyone in the attendees that has something to share for the good of the cause? If not, we're going to go to lunch, and we'll break till 12:30, I think. I'm not seeing any hands up. Do you see any hands up, Mr. Ripple, in the attendees?
I don't see any.
So I'm proposing we take a lunch break until 12:30. Does anyone think they need more time than that? Speak up if you do. All right, so let's, I will put our hearing into recess until 12:30. Enjoy your lunch.
Karen, do you need me to share?
No, I will share as soon as the chair is ready.
Okay, so being 12:30 and being that hopefully everyone's had enough time to eat a satisfying lunch, we're ready to get into the financials of the Medicaid area. You go ahead and start. Wait, Representative Irf has an initial question. Yes, sir.
I just ask a question touching on what we ended with last. You talked about the FMAP is here. Expansion, that was where the costs were. What is that expansion? Who is in that expansion population?
So the way the maintenance of effort is anybody who, as of the date of the start of the public health emergency, remains covered by Medicaid through the end of the public health emergency, regardless of whether there's a change in circumstance or not. That as a national policy, that to make sure that people have health insurance coverage through the pandemic, that if we ordinarily would have churn of maybe like 2,500 people a month, we don't have that because of the maintenance of effort requirement.
Okay, but still, I'm not. Who is it? What? I mean, you implied it wasn't people in nursing homes. So who is it?
It is people in long-term services and support. It's every category. If you go back to the trying to think of what slide it was in the slide deck. Give me 1 second here.
But it's basically just everyone who at the date of the emergency was in Medicaid for whatever eligibility reason continues with Medicaid throughout, regardless of changed circumstances.
Right. If you go to slide 11, Representative Irf, of the slide deck that was this morning, that shows you each of the categories, the growth in that. So it was, but just on a global level of the 37,000 increase, a good percentage of those are people from the MOE, and about a little more than half are granted advantage. And then the other part is the standard population. And again, I think the maps also give you a little bit of insight into that as well.
Could I follow up?
Sure.
Is that slide specifically talking about the enhanced FMAP?
That's the slide of people that have remained on Medicaid, or how the population growth has gone. But we could do something different in terms of I think your precise question maybe is how many people are the MOE category. We don't exactly know that number because we haven't seen whether people's circumstances have changed or not entirely.
I'm not really looking for what I'm trying to understand. The implication in your previous comments about when I was asking you about the nursing homes and those facilities, when you spoke about the expanded FMAP, the implication to me that I heard you saying was that that's not where the extra expense was. It was in some other age group, some other group of people, not the ones who are in the nursing homes or in those other long-term facilities. So could you just clarify that for me?
Sure. So as an example, in Medicaid, the health insurance program, as an example, we were operating at 177,000 or so individuals before the start of the public health emergency. We had to increase our contract limitation, for example, in the MCO program by almost $500 million initially to account for the extra enrollment that was going to be in that program. And so if you're talking about nursing home, we do know that the number of admissions because of COVID went down, but in home and community-based services and other parts of the Medicaid budget, there are increases in enrollment. So someone in the nursing home days went down. You're right, you're correct about that.
Oh, okay, thank you.
Do you have any other? No, okay, so as long as you prime that area, I'm curious if we are doing if there's any way for us to track people whose circumstances have changed that need to be disenrolled, or how it sounded to me like you already were aware of some that are candidates for disenrollment once the emergency is over, but to what extent do we have visibility into that population?
So we have visibility into, for example, people like children that age out of the children's category. We have visibility of people who are maybe were granted advantage and age into Medicare as their primary. So those are the types of things we have visibility on. Whether someone's income, for example, has changed, we have some visibility on that for certain groups of people where we can access certain databases, federal databases and state databases. But for other people, we don't know. But we know, for example, today there are about 18,000 redeterminations that we're waiting, or we need to know, which is about half the population of the 37,000 increase. We're waiting to see, whether at the time the public health emergency ends, whether for whatever reason would they continue or not continue to qualify. And that's when I was talking about the end of the public health emergency and the unwinding, we have to sort through that group to make sure that people who aren't eligible don't continue, but those who are, most importantly, particularly the vulnerable, mentally ill and other disabilities, that we make sure that people who are eligible remain eligible. And that's one of our biggest, I think, tasks. And again, I think when there's a ability to share the A&M report, you'll see that they have some comment on that as well.
So 18,000 redeterminations, that sounds like easily 6 to 12 months worth of workload.
We're not going to be able to let it take that long. We're doing pre-work. We want to do it in a considerably shorter time than that, Representative Edwards. We're trying to target it to get it done within the quarter that the federal match is available is kind of what we're working towards operationally.
All right, sounds great.
Thank you.
Are there any other questions before we start to break out the financial sheets? Okay, I think we're ready.
Great. All right, so just going to the end of Henry's presentation, you'll see here the first accounting unit is the MOM grant, which is on page 989, accounting unit 1371. Chair, if you're speaking, we can't hear you.
I'm just letting you know, I surfed to that part of my spreadsheet so I can see it more easily. And so this looks like it's all federal funds, and the federal funds are about to grow dramatically.
That's what we anticipate. I do believe that this is a grant that's awarded annually. So, you know, it's possible that things will change, but this is what we're anticipating.
Okay.
Why on these several
So,
pages do we show 0 employees?
There-
Uh,
there-
s-
go ahead,
There are
Karen.
no employees associated with this grant. The employees that help manage this grant are in the Medicaid Administrative Accounting Unit.
Thank you.
There is actually one position that's tied to this grant, and it
Oh,
is in
the temp
class
position.
59.
Thank you.
Right.
Athena.
And I just want to add too, that this grant was awarded January of 2020. So half of fiscal year 20.
so how many moms do we think we can service with $750,000 of federal money?
We're, I think, targeting approximately 300, between 250 and 300 annually.
Okay, does that also mean we have 300 moms who are pregnant and who are also on opioids, or is this a lot of prevention effort as well?
It could be both. It could be someone who is using or someone that is at risk of using, but generally it's targeted at those who, from a historical standpoint, looking at NAS babies, those that are addicted on birth, that we estimate, at least on a historical basis, that between 200 and 300 births of potential exposure in the greater Manchester area.
So what's the nature of this contract? We've got contract for program services. What kind of scope is in that contract?
So just from a bit of a background standpoint, it was the Manchester community came to the department to be able to apply for this federal grant because they were applying for 2 grants and they needed the state to be the state Medicaid program to be the, if you will, the lead applicant in it. So in large measure, the funding goes to the lead agency, which was, if you will, drafted from the Greater Manchester Medical Community, and that's Elliott Hospital. There, then would subcontract with other medical providers in their community. And this is not for direct services; it's for the coordination and development of follow-up. An ordinary, for example, mom might get 6 months of follow-up. The idea here is it'd be 2 years of follow-up to help make sure that if they're on the right track and remaining free of use.
So the follow-up implies that they're getting some sort of a counseling service, if for no other reason than to find out what their drug status is.
They may be receiving a counseling service, but that's not what this money's paying for. It's the part of tracking and providing the care coordination to get them to the various services that they need. Those services are billed to Medicaid directly.
Okay, are there any other questions about this? I'm not seeing any, but to your earlier question, was it Weiler or Irf, you talking about personnel? There is a temp full-time budget line, and
Yeah,
I
that was
assume
me.
that's okay. I assume that's what's paying for the help.
Yes.
And is that person employed in this department or borrowed manpower from a different department, and this is a cost transfer?
No, this is a temporary employee. New to the program, and previously had worked in the Department of Health and Human Services, but wasn't currently.
The position is not now vacant.
Correct.
All right. Very good. Thank you. You can go on. Unless you have something you want to make sure we know, I think we've asked our questions.
Great. The next accounting unit is 5201, which is the IDN fund, as Henry has already talked about, that waiver has ended, so this accounting unit is no longer budgeted.
Okay, I'm going to ask a similar question to the one I asked earlier. What did we buy with this money? Because we spent, it looks like we spent almost 11 million in FY20 and budgeted 26 million for this year. What did we think we were getting?
Karen, can I address that?
Yeah, please, Henry.
So I think it was a 5-year demonstration. And the things that we were able to demonstrate that are be carried forward are a number of different things that the department is working on utilizing. So for example, there's a technology for tracking admissions, discharges, and transfers so that when, for example, someone is admitted to the state hospital and that there be notification to their provider that they've been admitted, or if they're going to be discharged. It's a technology that is widely used by the MCOs, the various medical providers, and that being an example of where acting sooner on admissions and discharges prevent readmissions to the state hospital, allow for connection to their regular provider to coordinate medical information, to be able to provide better coordination of care, to reduce length of stay or reduce readmissions. So that's kind of one track of things. That's a technology and a process. Another thing was the employment and expansion of providers to treat substance use disorder. There was some 300 expansion of providers that treated SUD. There was coordination with, for example, the correctional system in some counties that once the treatment was, for example, for SUD was done in the prison system, to carry forward their coordination once they leave the prison system. So there's a lot of different features to improve care coordination, to improve transitions of care, to increase the capacity, the labor workforce. Those are just some of the things that we've got from this. I think that care coordination and care management are important aspects of what happens to control costs, and to, for example, in the earlier analogy, someone who's using the emergency room, tens of, maybe even hundreds of times, that being able to provide insight to different parts of the healthcare system to be able to intervene, to get them to the right level, at the right care, at the right time, right place, right cost. If that's helpful, Representative Edwards.
Oh, it is. It's you told me more than I thought I was asking, and that was helpful. I guess my last question here is, we, in the budget for this year, we thought we were going to spend $3.3 million, and that there was a $10 million local funds. I'm curious what those local funds are, and if both those budget amounts are going to be spent, or if they're going to be underspent.
So this is a bit of a complicated question, Representative Edwards, but let me try to keep it simple here. Part of the financing of this waiver came from county contributions, and obviously because of the pandemic, counties are having some of their own financial challenges. So some of what we expected to be able to obtain as the non-federal share, we're not expecting to obtain any further funds from the counties. So against a waiver that at one point could have been $110 million, is probably going to be closer to 75 or 80.
Okay, and so we are going to underspend. We're going to. How about the general funds? Are we returning some amount of that to the Treasury?
Well, there aren't, the way this waiver was structured, we were receiving money for, in certain programs in the department in behavioral health, public health, where the feds gave us money for areas that they would not otherwise typically match. And so in other parts of the budget, we're going to have to make up for the fact that those funds will no longer be coming to us. They were expected to be temporarily, and that's what they are.
I think what I just heard you say is, yes, we're going to spend the full 3.3 million. And because we didn't match enough on the federal money, we're going to have to come up with some more money in this budget year to transfer over. Is that what you just said?
Henry, can I jump
Please.
in?
Yeah.
So as far as fiscal year 21, I don't think that we're going to expend all that 3.2, but what I can tell you is that we have shortfalls elsewhere in the department that we're transferring general funds around, but our overall lapse for DHHS is expected to be in excess of $75 million for fiscal year 21. As far as 22 and 23, this gets back to a question that Representative Irf asked and is still an outstanding item that I'm working on, which was a behavioral health question, and the general funds had increased, and the question was, why did the general funds increase? What happened to the federal funds? That was related to this program. So the general funds that are budgeted here in fiscal year 21 are budgeted elsewhere in 22 and 23. I think what Henry is also saying is because this was a half of the year, this is only half of the year, the general funds that were moved elsewhere. However, in fiscal year 21, those behavioral health contracts would have been budgeted knowing that the waiver was ending. So there's not additional funds, general funds needed, but these general funds will be moved elsewhere.
Okay. All right. Well, that was more what I was expecting to hear, that kind of an answer. Fundamentally, I'm just looking at $26 million, and it was a demonstration project, but I wonder what was demonstrated that was worth $26 million, but we can go on.
Okay, great. The next accounting unit is 7937, which is Medicaid administration. This is where the Medicaid employees are budgeted, including the MMIS employees.
And Karen, also the transfer to other state agencies, being the state hospital with the dish.
Yes, the line 49 is the transfer to New Hampshire Hospital. Their dish payment is reflected there. So in New Hampshire Hospital, they receive it as other income. It's received as federal income here in the Medicaid budget. Thank you, Henry. Looks like there's a question.
I'm going to take a second and look at this. Are there any, lots of questions. Representative Wallner?
On that line, Karen, on the transfer, why is it so much more? What's the increase? What's causing that increase?
Athena, can you speak to that at all, or would we need to get that info from Joe?
Yeah, that's something that we budget based on Joe's projections.
So
are you looking at line 49? Is that the line we're talking about?
Yes.
Okay.
And that line 49 is 100% federal. There are no general funds in that line. Because the match to the federal funds for New Hampshire Hospital are essentially in kind. It's the general funds that are spent at New Hampshire Hospital. And actually DISH doesn't have a general fund match, now that I say that out loud.
Okay, so it's a $14 million increase. I mean, that's great if it's $14 million increase in federal funds. I just wondered why, what was the formula? What caused it to increase so much? Why did the federal government decide to increase that so much?
I don't think it's based on the federal government. It's based on a calculation of uncompensated care. So what I'll do, Jonah, if you can just put that on the questions, I'll make sure to have Joe provide that information as to the increase.
Thank you.
Thank you.
Any more follow-ups, Representative?
No, I'm fine. Thanks.
Representative Irf?
If I could just back up for a moment, Karen.
Yes.
The 1371, did that exist in the previous budget, that accounting of it? The maternal opioid misuse?
It only existed when it was created when we accepted the grant funds. It was not created during the budget process. I think we tried to create it during the budget process and Kevin told me I was too late, if I recall correctly. We got the grant award, I want to say, super late in that
December
fiscal
of
year.
19.
Yeah. Oh, so we were actually in the continuing resolution. When we
So
got
that was
the
a
grant.
federal fund grant? Is that,
Yes,
thank you.
1371 is federal.
Weiler? You're on mute, sir.
On the next page, you show additions of one classified, and unclassified for 22 and 23. Is that because of the increases in things, or who would we add unclassified?
Athena, do you know which position was, which unclassified position? Was that Brooks' position that was transferred?
I believe it was Brooks, yes.
Okay. So it came from somewhere else in the budget. I don't remember who held that position before her. It might have been in another division. As far as the permanent position increase, is that moving from somewhere else or is that the conversion? Because we abolished a position.
Yeah, that's actually a number of things. So we have a number of positions, a number of
You're fading out. The last few seconds was just completely faded out.
Sorry, is that better?
Oh, yeah.
Okay, good. So part of that are the MMIS positions that were previously unfunded in 20 and 21. In addition to, we also moved in 2 or 3 other MMIS positions that should have been moved in 2021. They were unfunded. We moved them in 22, 23.
Thank you.
No more follow-up there, Representative Weiler?
No, thanks.
All right,
Great.
Representative Wallner?
Sorry, thank you. So on line 102, contract for program services, it's increased by about $5 million. I was wondering what new contracts or what is that?
Sure. So this is contract funds that really are to support the entire department, but I anticipate that it'll come from Medicaid administration funding. So I put it all here. But these would be the contract funds to support the transformation projects in House Bill 2. So the funds in House Bill 2, the $10 million in general funds with the authority to accept any federal funds, those are to pay for the projects themselves, right? To implement the IT processes, to hire temporary employees. This fund is to hire a contractor to help us support that transformation. So project manage and research and analysis and all of that type of work.
Follow-up?
Yeah. So Karen, are you talking about in House Bill 2, are you talking about the Alvarez and Marsal, the contract with them? Is that what we're talking about?
So the $10 million that's in HB2 is not to contract with Alvarez and Marsal, it's to implement the projects that Alvarez and Marsal is suggesting we implement, which is the IMD waiver and the projects within behavioral health, as well as the DD system transformations. So that's for the actual department cost of making those changes. And this is to hire a contractor, whether it's Alvarez and Marsal or another contractor to help support us in making those transformations.
A further question?
Go ahead.
So this is an addition, this is a new $10 million to do the things that Alvarez and Marsal had in their review.
Yes.
So if I'm following this, then that is $10 million more than we spent last year. But last year we spent 7,800 and the year before we spent 5 million. So there's only 2,700,000 left. What aren't we doing? if we took the 10 million out for the Alvarez and Marcel, we would have 2 million left. What are we not doing?
Nope, so the funds in addition here, the 7 million to 12 million is about $6 million a year. The 10 million that I was talking about is in HB2. This is a separate appropriation, the 6 million in HB1. So the 7.8 is still budgeted here.
Okay.
Or just less than the 7.8, really bringing it back in line to what we actually spent, around 6, a little over 6.
Do you have a follow-up?
I'm just thinking about it for a minute. Can we get a list of what exactly we're doing with the $10 million that's in House Bill 2?
Sure, what I can do is provide an explanation of our plan. The part of the problem is that we still have planning to do. And so what you'll see in the Alvarez and Marcel report are ranges to implement many of these things. And for many of them, we chose a number that was sort of in the middle of the range. But part of the reason that it's an HB2 and Matt, the governor's budget director, alluded to this, is that we're not sure exactly where everything is going to land. So the governor's office was trying to give us some flexibility to say, you need to implement all of these things, but it could be that implementing the IMD waiver ends up a little more expensive than we anticipated, but one of the other things that we're implementing ends up costing a little bit less. So that's the reason that they put it in HB2 to offer us some flexibility around that. But I can definitely give you the projects that we're looking to implement with those funds.
Thank you.
You're welcome.
So I have a question for Mr. Ripple, and then we'll go to Representative Weiler and Irf. So Mr. Ripple, this weekend, as you were working hard during the weekend, your off hours, one of the emails that you sent me sounded like you were going to take the HB2 items and put it into a spreadsheet so that we could see where we thought those HB2 items were lining up. So are you going to be like trying to do any sort of gross aggregate or gross allocation against any of these budget areas, or are you just going to do an overall, here's $10 million associated with A&M, associated with DHHS? How precise?
I was going to do an overall, because the $10 million for Alvarez and Marcel, for example, I don't know where that would be distributed throughout the department. So at this point, I don't think I have the information to align it with specific accounting units.
Thank you for that. And that's going to be a helpful spreadsheet, I think. So Representative Weiler?
Thank you. I've heard this IND waiver a few times, and I didn't find it in the list of acronyms. What does it stand for?
Oh, I will have to ask John to add it to the list of acronyms. Henry, do you want to?
Yeah, it's institutions of mental disease that the feds, as you know, Representative Weiler, when someone's admitted to the state hospital, as an example, that they limit the amount that they pay, and the rest of that obligation rests with the state in general funds. What the IMD waiver would allow is for the state to be able to access additional federal fund matching for care of people who are admitted to different facilities, including the state hospital.
Thank you. I guess I was looking it up wrong, because I thought I&D or I November D, but I didn't look it up on IMD. I kept hearing it as IND. Thank you.
India Mike Delta.
Yep.
India Mike Delta. Okay, Representative, do you have a follow-up, sir?
No, I don't. Thank you.
Representative Irf?
Thank you. It's M? I thought it was N as in Nancy. That's not my question, but.
Doesn't
Yes.
matter.
Mike?
Okay. So my question is on that line 102 that you've been talking about, contracts for program services. Is that all federal funds?
I believe it's 50-50, Athena.
Correct, 50-50.
Thank you.
Questions at this point? Do you remember where you left off?
Okay. So the next accounting unit is 7939, which is the state phase down or dual eligibles that the state is required to fund. This is 100% general funds. There is a prioritized need around this. So what I would tell you, and Henry could give you some background on what the program is, but one of the complicating factors of this program is that we find out in October of the fiscal year that we are in what the rate we're going to have to pay is. And so there have been traditionally rate increases. So we do have a prioritized need for that. The reason that fiscal year 20 actuals are so low is because of the enhanced FMAP. They process the enhanced FMAP on these expenditures as a credit to us. So that is why it is 45 million and not closer to the 48 that I believe it was budgeted at.
If kind of think about it in the simplest terms, it's Part D subsidy for those Medicare beneficiaries who also qualify for Medicaid dual eligible that is paying for their prescription drug benefit. And the amount that the state has to be paid is based on a historical for each state in terms of what their historical spending on pharmaceuticals have been based on a trend factor. And as Karen said, we've been fortunate in this period of time to get some enhanced FMAP to cover it, but we, depending on how long that enhanced FMAP is available, and at the time we did the budget, we didn't know, and we still don't know exactly how long it's going to be available, that there would be a shortage over what was in the governor's budget if it ended under the assumptions that we had.
So what's your ballpark estimate of how much this is going to be short, do you think? What's our risk variable here? What might it be?
Tina, do you want to grab that one?
Yeah, so roughly in 22, it's about 2 million, and in 23, because it's compounded, it's about 3.5.
What I would say, as I know that general funds are certainly in demand in this budget, is that one thing that could be very helpful is to add a class note here to allow us to carry the funds over from 22 to 23, where the public health emergency is likely to go until at least December. I think that this 48 million might be okay to get us through 22 and potentially even be some funds left that we could carry into 23 and then have enough funds in 23. So
unless you have a class note, you can't do that. You can't just.
Correct. Correct. If there's no class note, it lapses at the end of the year.
So, Mr. Ripple, can you add that as something that we ought to consider favorably?
Yes.
Thank you, sir.
Thank you.
Representative Wallner, you have your hand up.
Yes, I just wondered how many people are in this would be dual eligible? How many clients do we have in this area?
A little over 19,000. Give you the number if I just look it up for a moment here.
$20,016.
Has it been going up? Did you see an increase in this area during the pandemic?
Yes, some slight increase. It's about 1,000 up, I think, or roughly that or so. So 1,000 on 19,000.
Okay, thank you.
Thank you.
So moving down to 7943, this is the Uncompensated Care Fund, otherwise known as DISH. So there are no general funds in this account. The private local funds coming in here is the Medicaid Enhancement Tax that we receive from the Department of Revenue Administration, and the federal funds is, of course, Medicaid. The reason you see a higher federal match here in fiscal year 20 is because of the enhanced FMAP. Typically, it is 50-50. And Athena, correct me if I'm wrong. Oh, no, never mind. Is it? Yep. No. Is there a typo on the federal funds in fiscal year 22? No, there isn't. Sorry, I missed that it was 119 million, 118 to 119. The audit fund set aside class 41, and this is true throughout the entire department, never has any general funds in it.
So that's a very weird match, right? I mean, that's almost like 49% to 51% or even smaller.
So if you took out the 118,980 here, then it would be 50-50. The 118,980 is 100% federal.
All right, Representative Wallner, you have a question followed by Representative Weiler.
No, I'm fine. Thank you.
Weiler?
Private local funds, where do they come from?
That's the Medicaid Enhancement Tax that comes from the Department of Revenue Administration.
Thank you.
You're welcome.
T, as we call it.
MET, yes. MET, MET.
Any other questions here? I'm just curious how you estimate this. On what basis are you estimating what the uncompensated care fund needs to be or wants to be?
So it's really based on the Medicaid Enhancement Tax and what the anticipated Medicaid Enhancement Tax is. Because MET is administered by DRA, they are primarily responsible for coming up with revenue estimates for MET. We do assist them to give them a sense of what the current market, if you will, of the hospitals looks like, what the, how the current revenues might be affected, et cetera, et cetera. But that is where that number comes from.
So with the extra people on Medicaid, because they were protected during the pandemic from losing eligibility, I would just, is that why we went from like 128 million in 20 to 123 to 119?
So the higher federal funds in fiscal year 20 is because of the enhanced FMAP. So that was probably actually budgeted somewhere closer to that 123 number. So the reduction that you're seeing from 21 to 22 is really related to the pandemic. The tax is set, the tax is paid on the previous calendar year of when they pay. So in fiscal year 22, they will be paying the tax on net patient service revenue. I did audit the Medicaid Enhancement Tax when I worked for DRA, but my knowledge is starting to fade. So that would be based on calendar year 21, which we all know has had some decrease in hospital revenue.
Representative Weiler, your hand is up, sir. Okay.
Lord,
all right.
thank you.
Do you have a question? No? Okay, go ahead and you can continue.
Okay. So moving along to accounting unit 7945 is EHR incentive payments. And I would need Henry or Athena to remind me what this accounting unit is.
This goes back a ways, Karen. This was an incentive that I think came out in 2008 or 2010 for healthcare providers to adopt electronic medical records. It was financed at the Fed level on a 90-10 basis, 90% Fed, 10% state. The program is ending. What you're seeing is that the costs that we're carrying in 22 and 23 are largely related to the administration of the auditing and the final claims by the healthcare providers. And Medicare ran a similar program, basically. This is the Medicaid side of it.
So do we have good data from this payment programs so that we know the extent to which the EHR has been implemented in New Hampshire and where we still have people who are not on EHRs like loan providers? Is there good, do we have good data because we had this program?
We would have good data on those that participate in the program. We wouldn't necessarily have full insight into those who didn't ever apply for it. But I think we could probably, from the data that we do have, make some good educated assessments of where the gaps might be.
Sometime in months from now, I'd be curious about our EHR penetration rate and where we're still lacking providers who are still not on an EHR. But that's not for this budget drill.
Sure.
Okay, are there any questions here? All right, I'm not seeing any. We can go.
Okay. Moving along to 7948. This is the department's largest accounting unit. This is Medicaid care management. This is standard Medicaid. The private local funds in this accounting unit are the remainder of the Medicaid Enhancement Tax that is not in the DISH account. You will also note here that class line 535 and 563 are the two accounting units from DCY, or two class lines, I'm sorry, from DCYF, and those are DCYF expenditures that are Medicaid expenditures. And that is a vast majority of the increase in this accounting unit.
Okay, so there are no personnel here because they're all over on that Medicaid administration line?
Correct.
Representative Wallner has a question.
Yes, this would be where in 20 and 21, we would see the 3.5% rate increase for providers. Is that correct?
The 3.1% rate increase, yes.
Okay, and so that has not carried, well, we carried it. I mean, we didn't take it away from them, but there's no new rate increase in the next budget.
I believe that's what Henry testified to, yes.
Could you tell me how long had Medicaid providers gone without a rate increase before the biennium we're in now?
Representative Wallner, thank you for the question. I think there'd be a variety of answers, like, for example, hospitals, where I'm a bit familiar with it. It's been, decades since their last increase. For physicians, somewhat similar, but it ranged from a few years to a couple of decades potentially in some instances. Like home health was another one that I think had some increases along the way, but we could give you something more specific on that. I just don't have them all making this.
And that rate increase is strictly a federal decision?
No, that was a legislative decision in 2019 to provide two 3.1% increases and effective January 1st of 20 and 21.
So the decision not to increase the reimbursement rate has been a state legislature decision?
Yes.
All right. Representative Wallner, your hand is up. Do you have a follow-up?
Yes, I do. So could you speak for a minute, I know we had gone for many, many years in a number of areas. Can you speak for just a minute about what the ramifications of that were? Were there providers who actually did not accept Medicaid? What happened? What were some of the outcomes of not having a keeping pace with cost of living, cost of medical care for our providers?
So I think it come at it from two different angles. One was sort of access issues. We were able to, if you will, satisfy access. I think what the strong pressure that we got from providers on a legislative level, I think in 2018 and 19, was a function of that in terms of the cross subsidies that meaning, what you can collect from commercial insurance, what you can collect from Medicare, that the ability to cross-subsidize Medicaid was not able to be handled anymore by many provider types, and they needed a level of increase. I think that I would note that, for example, in the DISH program for hospitals, that there is some compensation for uncompensated care, and that's outside of the rate increases, if you will, that continue to evolve. Again, not necessarily keeping up with the full cost of uncompensated care. And the county nursing facilities receiving supplemental payments in terms of the MQIP, Medicaid Quality Incentive Payment, and ProShare that helped to defray some of the costs. But I think it just became, fairly universal that, the ability to support Medicaid standalone and maintain the level of Medicaid patients within a particular practice, that I think the pressure was being felt there. And I think the legislature also acted in 2018, I believe it was, to improve mental health rates, which was carried forward into 19 and 20 and 21. There was investment there, and SUD rates. Those are two rates that, where there was significant pressures that did have some intermediate help on. But I think even there, that, continuing to sustain that. And then the transition when, if you remember, Medicaid expansion was originally on the exchange, and so that the reimbursement rates for the expansion population at one point were allowed to be higher, and then the federal government, and then the transition for the state to move back the expansion population into the standard program represented a rate cut and savings to the state as well. So I think all those things combined together led to, the provider community saying we need some relief here more than what has been able to be funded in the prior couple of years.
Further question?
Yes.
So, Mr. Lippman, when providers can't keep up when Medicaid does not keep up with the cost to the provider, do you think that then gets pushed back into the private market, and the private insurance ends up being higher because Medicaid has been underfunded?
I think in part it does, but also in part, I think the adjustments to the DISH program, for example, were intended to help offset that. And the fact that today, or at the time, there's 50,000, now 70,000 people who had no insurance now have some level of coverage. That those things taken together, I think, were intended to help provide some relief there, albeit maybe not 100% relief.
Thank you.
So leveraging off of what Representative Wallner just said, I think you made an offer, Mr. Lippman, to give us a history of the rate increases or lack thereof. I would like to see that. And it sounded like sometimes the rate increases were bifurcated towards particular clinical areas. If you could make that distinction, if there is one, I'd like to see that.
I think that we should be able to look to Athena here. I think we have records of different, if I could go back maybe a decade or something like that, 10 years, that might make it a quicker turnaround than having to go back 20 or 30 years.
I'm not looking for the hard stuff to do, but if you can do a decade pretty easily, that's relevant.
Sure.
Representative Irf, your hand's up.
Yes, thank you. Karen, could you just remind me what line was the DCYF included in? Is that 535?
535 and 563.
Both of them. Okay, thank you.
Yes.
Question. Are there any other questions in this area? It is a lot of money. So I guess I have a similar question. On what basis are we coming up with an estimate for, say, the federal funds on 000 for Medicaid care management?
I could take that one, Karen.
Sure.
So I think underlying the Medicaid care management program is that the state uses an actuarial firm to develop the expenditures, and that the federal government has certain standards with respect to historical periods that you have to use. And so the Medicaid, if you will, expenditures through the managed care program receive quite a bit of work in their development, looking at various spending patterns. For example, pharmacy is like 18 to 20% of the spend in the managed care program. We have the actuarial firm has experts in the pharmacy area to help look at what's being spent. We have a formulary that's reviewed, but basically we have to meet a certain federal standard in order to, and it has to be approved by federal actuaries as well before we can get a rate adopted. And that's the basis in which we can draw a federal match. That federal match is then driven off of the beneficiaries type. So for example, for the expansion, it would be 90% federal. For a CHIP, for the higher reimbursement CHIP group, it's going to be 64.5% in the next biennium here. And for the standard population, it's 50%. And so basically the derivative of the federal match is based on what the actuarial expected expenditures are for the population. And each of those populations is studied separately.
So we do have some levers still of controlling our spend by things like making an eligibility decision around healthy people or people with the ability to go get a job, putting them on Medicaid eligibility, or if we came up with a silver bullet and found a way to get our pharmacy costs down. Those are things that we could do that the actuaries would factor in.
Yes, as well. Like for example, pharmacy is a good one where we one of the things that you'll find if you do some research on where can Medicaid programs affect their spend is, moving it to a statewide PDL pharmacy drug list. It helps the state enhance its rebate position, and also makes it easier on providers to prescribe because there's more consistency. But other things that we talked about earlier, the IDN as an example, different care management interventions, someone was using the ER 30 times a year, who's now using it twice a year. If you look at different areas of utilization, that our biggest opportunity in managing the program, aside from the number of people enrolled and the type of people who are enrolled, is by managing it so that there's the appropriate utilization, the right care, the right time, the right place. That's where from a transformation effort standpoint, I think the department is trying to strengthen both what it does and what the provider community does in terms of trying to if you will, right position the care that's delivered. That's our biggest opportunity. When you look at the administrative spend versus the medical spend, 89% of the dollars here are going towards paying providers for the services that they use, and trying to make sure that those services are appropriate and needed are what's a big part of what the managed care organizations do, as well as the department. And then on top of that is the program integrity activities to make sure that the department is not experiencing fraud, waste, or abuse.
Great answer. Thank you. What other questions are there in this area? I'm not seeing any, so you can continue.
All right, great. The next accounting unit is 7051, which is the Child Health Insurance Program, which Henry has spoke about extensively. This accounting unit is fairly new. I believe it was new in the 2021 biennium. It used to be that these expenditures were included within 7948. And because that accounting unit had become so large, and due to an audit finding from KPMG, we now do break out 7051. And Athena, correct me if I'm wrong, but the new agency income there, is that, no, I'm gonna ask you what it is. I'm not gonna guess.
So the increase in, or the addition of the agency income are the drug
Yes.
rebates that are related to the CHIP population. Previously in
Perfect.
2021, we had budgeted those rebates in 7948. But I
Great, thank
do
you.
want to mention the increase, or rather the decrease in the federal funds over the years. In Fed fiscal year 18 and 19, that federal match was 88%. In Fed fiscal year 20, it was reduced to 76.5. Although again, in 20 and 21, we're seeing the increased FMAP here as well. In Fed fiscal year 21, that standard CHIP match goes down to 65%.
55%. So my math is wrong, because looking at FY23, the 73 million versus the 37 million, that doesn't look like a 55% match.
65%. 65% federal, but we also added some agency income for the drug rebates.
I'm sure your math is right, but it still doesn't look like we're coming up with our 45%.
It's 35.
35 general.
Minus the drug rebates.
Did I hear you say the federal match was 5.5 or 6.5?
6.5.
Oh, that's the problem right there. My hearing. Okay, Representative Urf, do you have a question?
I just couldn't hear the word, the one with rebates. When Athena
So
was
the agency income here is drug rebates.
drug rebates. Thank you.
You're welcome.
Drug or vaccine?
Pharmaceuticals other than vaccine.
You have a follow-up, Representative Urf? No. Representative Weiler?
Thank you. I missed hearing the number of clients.
And
I believe Henry's looking it up.
Yeah, I'm looking it up too.
so the children, the low income children, 76,790, and the CHIP, the enhanced match CHIP children are 17,312.
What's the 17,000?
The one where we have the eligibility from 196 to 323% of poverty. That's where we get an enhanced match on that population of children.
Did
So
we
the-
have law that increased?
I'm sorry, didn't hear your full question, Representative Lott.
No, I mean, who decided to go to that increased way up to 300% of poverty? Was that something we put in the budget, or was it something the feds told us?
No, I think it was something that the state elected to do probably in the 90s when it was available.
300% seems pretty generous.
I think it's, again, I think nationally it averages 255. I think that the idea is, I think from a policy standpoint, has been that covering children and making sure they get their well child care and it defrays costs in other areas of your budget later on, and like DCYF and other extended medical costs. And I think that was the basis that it was adopted.
Family of four, off the top of your head, what's 300% of poverty?
So roughly about four, I think it's around 16,000 is poverty, right? Is 4 times 16 would be about 64,000.
Oh.
If you understand, like a family, commercial
Family of
family,
four usually was about 20-some thousand.
I think I'll have to, I don't have it, I guess off the top of my head, I know for a single person it's 16, that's what I was using as the
All right.
multiplier. But if you look at what a policy costs for a family plan, it's in the commercial market, it's well over 20,000.
Wow.
And so if you think about what the target for someone spending on the exchanges is, somewhere between 2 and 8.5% of income. That's a lot of children may not otherwise get covered, is I think why that they go up to that level.
Insurance companies have gotten awful greedy. Thank you.
I mean, everyone is seeing it for themselves. It's just a huge impact on the general fund, going from 17 million in 20 to projected to go to 37 million in 23. That's just a very large increase. So what if we were to project this out another budget term or two? Is this growth rate? This growth rate is not going to continue, is it?
No, the increase between 22 and 23 is that group of CHIP kids that you were just speaking about. They were previously budgeted in 7948, but again, because they're eligible for the same enhanced CHIP FMAP, we budgeted them in the CHIP accounting unit.
So a lot of what's got my attention is an accounting transfer.
Yes.
Yes.
All right.
Yeah.
Are there any other questions in this area? I'm not seeing any.
The next accounting unit is 8009, which is Medicaid Management Information System, or MMIS. I believe Henry spoke extensively about this. This area does have a 90-10 match. And part of what you're seeing here is the part of the increase is because of implementation of the modular MMIS that Dave Weeder spoke about earlier, where you do have to run two systems simultaneously for a period of time. And so then you're sort of paying a little bit more for a period of time until you make that full transition. So that's why the expenditures are a little higher here. I do anticipate as the project fully implements that we'll see these expenditures level out.
Representative Nordgren.
Hi, good afternoon. Could you indulge me to go back to 751? Could we have a history of the increases and also acknowledge what income rates those would be? Can we go back a few budgets?
I'm sorry, are you speaking about 7051?
Yes.
I think as Henry spoke about it, the 300% goes back to the 90s, but we can certainly get that information.
Well, and I think the income levels would be helpful too.
Okay.
Okay, thank you.
You're welcome.
Okay, so I think we're back to MMIS, and in FY21, we're at 3 million, and I understand we've had a lot of vacancies and a lot of borrowed manpower, and we're going to jump to 12 million in FY22. And I heard you say we're going to run redundant systems for a while until we can cut over and go live fully on the new system.
So what I would mention is fiscal year 21 here was substantially underfunded. It was not funded in the phases of the budget. As you can see, fiscal year 20 is much higher. The general funds are much higher. So we've actually needed to transfer funds into there. If we haven't done it already, we're going to before the fiscal year ends. So I would mention that about fiscal year 21.
I think we needed 13 million to complete additional funds to complete 21 that we had to find, and the new contract anticipates that we'll be funding some of what Karen was talking about, which I think is about 12 million of it.
So this number will land somewhere around 33 to 35 million.
Okay. All right. Well, sometime after March 25th, I would love to have a deep dive into this project. And I don't know if it has to be a whole Division 3 thing, but I would like to see this project closer, because I think what's going to happen is the Senate will take our budget and they're going to come back. And so I have some time to get smarter here. There's a lot of money and a lot of benefit from doing this, and I just would like to see it if we could.
We had done a presentation for the Governing Council, a business presentation this last week, and so we'll be working on this because we have to bring a contract forward before the end of the state fiscal year. So we'll be putting together information.
All right. Well, thank you. And certainly I don't need anything before the 25th. All right. Are there any other questions here? I'm not seeing any. Are we done? Was that it?
Nope. One last one is Medicaid to schools, which is 100% federal, which I believe you talked a little bit about in Chris Santinello's presentation.
So this concept of Medicaid to schools, I think I saw Chris on earlier. Are we actively working through the DOE so that as they add, like in our local Auburn Village school, we added additional renovation space, and we added like an occupational therapist area and a physical therapist area. And as I was looking at the clinical staff that was going in there, I was thinking, well, we're really close to having a full-on clinic in here. Can we really start building Medicaid for this clinic operation we're running inside the schools? Is that really what this is?
For Medicaid eligible students where services are provided in the school, yes, that is what this is intended for. And I mentioned earlier the Senate Bill 684 from last session, that the telemedicine is available to the schools. Basically, any service that a qualified treatment provider, meaning someone who is duly licensed by their appropriate professional board and it's a covered service under Medicaid, that schools can bill the Medicaid program for. And but what schools have to pay is they contribute 50% of the cost. In other words, they do what is called a certified public expenditure. And so when they bill the state, half of it is covered. They get half their money that they would otherwise do because they're responsible under just like we have to do in other parts of the Medicaid program, cover a minimum of 50% match, except when there is this enhanced FMAP situation. The schools would only be responsible for 43.8% of the cost, and they could get reimbursement of the 56.2%. And what ended up happening is there was in between 20 and 21 is in 20, we had to recalibrate the program for, new guidance or clarification of guidance, and the work with the legislature on some things and the Office of Professional Licensure on others, so that in the long run, schools will be able to do this. We are working very close with the Department of Education on this. We participate in a couple different ways on this. I think one thing that there's the New Hampshire Charitable Foundation has put together a work group of both Department of Education, Medicaid, as well as other stakeholders like school districts to work together, and most recently approved a grant to help develop a cooperative to support schools so that they can take further advantage of the Medicaid schools program.
What's our penetration rate? What percentage of schools in New Hampshire do you think are leveraging this program?
To some degree, I think there are 172 school districts. I think there are only approximately 9 that don't participate in it at all.
was my argument in in Division 2, was that we were never able to find out when a district says we spent 3.5 times the average cost per student. So now we want to go to the 80% match for special education funds. And you didn't know whether that 3.5 times was coming from Medicaid for schools or where it was coming from, and they wouldn't tell you. And they always hid behind HIPAA. So I think we ought to have something in HB2 to say that you can't count that money in the 3.5.
Did you get a note on that, Mr. Ripple? Do you have any follow-up questions of Representative Weiler to make sure you understand what he's asking for?
Yeah, that one I didn't quite catch, Representative.
When we were in Division 2, and we're talking about when a district decides to go to the catastrophic aid, to spend 3.5 times the normal cost of a student, and then they can ask for catastrophic aid and they get 80% of the costs up until they spend 10 times the average cost, at which time catastrophic care takes over 100%. So if they were getting money from other sources, like Medicaid to schools, they would still count that in the 3.5 times. And if you said, are you counting any other monies other than your own district funds? They didn't have to tell you when they wouldn't. I didn't think that was fair.
Okay.
Kevin, if I could, what the schools can collect under Medicaid to schools is 50% of the, generally 50% of the Medicaid fee schedule. And during the enhanced FMAP, it's 56.2% of the Medicaid fee schedule.
Well, I'm not seeing any other hands. Representative Weiler, did you have a follow-up?
No, thanks.
Okay. All right. So now I think we're done. Is that right?
That is correct. We are done with the accounting units in Medicaid.
That's getting us very close to being in overall. Representative Erf, do you have a question?
I was wondering if I could ask Karen about 3 accounting units, just to know if they were existing in FY21.
Okay, I will do my best. Go ahead.
CSBG, which is 7148,
What area was that in?
Bureau of Family Assistance.
And then we don't have any expenditures in there for 22 and 23?
No. In you don't have it in there for 21. Sorry.
I think
the
that got,
new accounting unit.
I think that got moved from DCYF.
Okay. And then 7215 SSBG, also in that same Bureau of Family Assistance.
I think that's the same thing, but I'd have to double check.
And then 7216, a kinship grant.
That one did come from DCYF.
Okay. When you say came from, as new entities?
As in, it was previously budgeted in DCYF and we moved it to DEHS. I think Joe Ripsum talked about it in his budget presentation.
I guess what I'm saying is, what would it just be a sub part of one of those, or would it be a separate standalone thing? Would I be able to find SSBG and DCYF?
I don't remember if they were standalone accounting units in DCYF or not. I'd have to get that for you.
Okay, thank you.
They were more likely just absorbed in a different program, I would guess.
Probably, but I'm not entirely sure.
Okay, Mr. Lippman, you've talked a lot. Do you have any sort of summary thoughts for us after we've gone through all of this? And as we're freshly broken through all the brush, do you have a big picture view for us as we summarize?
I guess the big picture with respect to what is going to be available from a federal matching perspective based on the length of the public health emergency is something that we will have to continue to evolve as we move through the phases here. And I think that some of the priority needs that were identified could be affected by that as well. For example, we talked about the state phase down. In terms of from an operational standpoint, filling in some of these vacant positions are really important. If we can't move forward on IT projects without staff, and that it's important to do so that we don't lose federal match in that area. And in terms of things like dental, I think that you and your colleagues will, I think, be judging what's in the two bills that are moving through the Senate and the House. I think that you can't disconnect the mouth from the rest of the body, that there are long-term, while there's some short-term costs, there are long-term benefits, I think, of, as you've pointed out, Representative Edwards, in terms of not ignoring those types of situations. I think that, we run a pretty lean and efficient program overall. There are opportunities to improve, and I think we disclosed some of those in our quality presentation that we're going to continue to work on. And we appreciate the support that you can provide to the beneficiaries that we serve in this budget. I don't know if Athena or Karen, you would add anything to that?
I think so, other than just saying thank you, Athena and Henry.
All right, well, thank you. And then I see 45 attendees, and we're going to give it a few seconds for somebody to see if they want to raise their hand and make a comment for the good of the committee, so we learn something more about the budget decisions we have to make. Give it a second. I'm not seeing any hands going up. All right, Mr. Ripple, I'm getting ready to adjourn. What have I forgotten?
I think you have one more set of presentations left, right, Karen?
Yes, long-term supports and services.
Oh, is that today?
Yes.
So we shouldn't adjourn. All right, let's go. I thought we were done. I'm sorry. It's
That's a very long presentation.
It was. Okay, let's take a
What's the schedule for tomorrow?
Schedule for tomorrow. We don't meet tomorrow. Everyone's got town meeting day tomorrow, so I don't think we have anything in the House calendar. Mr. Ripple, what are you going to say?
Don't we meet tomorrow afternoon?
You do actually. That was last week. It was decided that you would meet tomorrow starting at noon. So you do have some time set aside tomorrow, and it's not for anything specific at this point. So if you wanted to continue with this presentation tomorrow instead, you could do that.
I would say that this
Ready to
presentation, I was just going to say, I would say that this presentation probably will take at least 3 to 4 hours. So I don't know if you want to start it today and finish it tomorrow.
Are you available to support it tomorrow afternoon?
I am with you however many days and hours you need me.
Oh, I mean, the department head. I don't know who's.
Yes. Yes, I did speak with Deb Sheets as well, and she is available whenever you need her to be available. So she can be available tomorrow as well.
So I guess I didn't look at the calendar very well. What time do we start? Noon tomorrow?
It's noon
Or
tomorrow,
1?
yes.
So is this technically an adjournment for the day or a recess till tomorrow?
You could adjourn for the day.
All right. So I'm not seeing anyone suggesting that we shouldn't adjourn. Let's go ahead and adjourn this meeting today and restart tomorrow at noon.
I have.
So, thank you. You can stop
recording.